We'll get started. This is our second annual Wisconsin Primary CNS Symposium, and good morning, everyone. It's my great pleasure to virtually welcome everyone to the state of Wisconsin. We're lucky to have two great academic institutions in the state of Wisconsin, UW and MCW, and between the two cancer centers and in collaboration with our community oncologist colleagues, we provide comprehensive cancer care for the entire state and beyond. And our goal in creating this educational activity is to improve the cancer care of Wisconsinites by providing updates on cutting-edge development in terms of surgical advances, clinical management, and innovative clinical trials in the field of primary brain tumor. And this year, we will focus on meningiomas as a symposium that we organized together with Dr. Bovi. So I'll let Dr. Bovi.
Thank you so much. Mahua, can you guys hear me okay?
Yeah, now we can.
All right, great. So I'd also like to welcome everyone this morning to our symposium. We're very excited to hear the panel of speakers that we have assembled. As Mahua had said, we're going to take a deep look into more modern approaches, actually, to very common diagnosis in the form of meningioma. As far as an introduction to our topic today, it's really my pleasure to introduce Dr. Shekhar Kirpad. And Dr. Kirpad is one of my colleagues at the Medical College of Wisconsin. He's the Sanford J. Larson Professor and Chair of Neurosurgery at the Medical College of Wisconsin. And it's my pleasure to have him introduce our topic today. Good morning, Shekhar.
Morning. So I'm going to thank you very much. It is an honor and a privilege and a delight to be asked to give introductory remarks for this symposium. It is really nice to know that a national level CNS Malignancy Symposium is now in its second year, and it is being run from Wisconsin. I'm an adapted Wisconsinite, and it is a remarkable event that's been put together. Events like this do not occur without folks that put them together. So I think I'd like to start by thanking Brittany Burrows, Chad Kruger, for really organizing the backbone of the symposium, especially in the virtual world. Although as we transition into an in-person world, their contributions will be equally important. So thank you both. The vision for the symposium really comes from Mahua, Dey, as well as Joe Bovi. Organizing a symposium like this and making it sustainable requires a lot of forethought, and really both Drs. Dey and Bovi deserve to be complimented for their incredible efforts in pulling this together and making this a national level symposium. And I really love the overall future vision for the symposium to make it an annual event jointly sponsored by the University of Wisconsin and MCW. Today's symposium, as Mahua mentioned earlier, features meningiomas, a really significant part of CNS malignancies. And just looking at the panels and the way that the symposium has been organized, this is going to be a real treat, not only for the panelists who can learn from each other, but also the faculty members that would attend, and especially for the learners. I think this will be a real treat to hear from national level superstars in terms of surgical perspectives for meningiomas, radiation, proton beam therapy, pathology, and translational advances. So really, it's a star-studded lineup of speakers. I want to limit my comments to as short as possible because I too am excited to hear what the speakers have to say. And with that, I'll end my welcome remarks. So welcome. I also want to add a little note that in addition to the two cancer centers, I actually represent also the newly created Neurosciences Institute at the Medical College of Wisconsin, which is a joint effort between Medical College of Wisconsin, our partners Froedtert Health and Children's Wisconsin, because CNS malignancy by its very nature, is critical to neurosciences as well. Again, thank you for the invitation. Look forward to the sessions.
That's great, Dr. Kripat. Thank you so much for those kind remarks. Let's kick off with our first speaker today. It's really my pleasure to introduce Dr. Nathan Swagerman. I've had the pleasure of working with Dr. Swagerman since he joined Frederick Medical College of Wisconsin in 2017. He had come to us with phenomenal training from University of Pittsburgh in neurosurgery, followed by fellowships in endoscopic and open skull-based surgery. He's really regarded as an expert in the field, and he is on really an exponential trajectory in terms of his career, and really excited to hear his talk today about surgical approaches to meningioma. So Nate, thanks so much for joining us, and we'll turn the stage over to you.
Hey, thanks, Joe. I really appreciate it. This has been a real pleasure to put this together, and obviously you guys have done a lot of work. I want to thank, again, Brittany and Chad for their great work in assembling things, and then yourself and Dr. Dey for really kind of putting together a star-studded program. I'm really excited, as Dr. Kripat had said, and as I'll reiterate, this is really exciting for us, and to see all the names on this topic, and specifically to talk about meningiomas, and something I'm very passionate about. Well, as I was saying earlier, I'm excited to talk about this. This is something I'm passionate about, as Joe knows, and this is something that we spend a lot of time talking about, and a lot of time operating on our patients who have this pathology. So again, I want to thank Chad and Brittany again for a wonderful job, again, helping me with my technology insufficiencies and getting things going for us this morning. So without further ado, I'll talk about meningioma surgery. One of the things that I like to talk about when it comes to meningiomas is that they're extremely common. And as everyone knows, we see a lot of these in clinic, and the question becomes, when do we have to intervene, and what do we have to do about these kind of things in order to really improve, A, the quality of people's lives, or B, prevent problems. And I'll talk a little bit about that as we go forward more thoroughly. But when it comes to meningiomas, again, this is a problem that we see pretty frequently. I have nothing to disclose, at least not yet. We'll keep working on things and trying to improve the process as we go forward. When I was putting this talk together, one of the things I see a lot of, and we all have, is what I didn't want to make this is a presentation talking about how I do things. And I think we've all seen different presentations talking about how the best way to take care of these problems, and people doing masterful surgery. But at the same time, I really want to make this practical from the aspect of people seeing what we're doing here, what is done elsewhere in the country, and understanding kind of the broad strokes of how we manage meningiomas, specifically when we talk about surgery themselves. As we all know, meningiomas range in their aggressiveness. They can be either benign or malignant, and that's classified based on the WHO grading scale that goes from 1 to 3. The vast majority of meningiomas that we see are going to be grade 1s, followed by more aggressive tumors, grade 2, that are more likely to come back, and then finally the malignant ones, which are grade 3s, which are really quite a low percentage, but oftentimes we can see and present problems themselves. The typical treatment for meningiomas involves surgery and radiation, oftentimes both of those options. And there are some chemotherapeutic options, although those are limited. But as we understand the genetics of these tumors more, obviously more opportunities for intervention are going to come forward. The trouble with meningiomas is often difficult to judge the grade purely based on the imaging. Oftentimes we'll see pretty what appear to be aggressive looking tumors, and they come back as benign, or more benign appearing tumors that come back as more aggressive. And so unfortunately our radiographics right now aren't able to classify them. And so oftentimes it's up to the surgeons and the pathologists to determine what's going on once we get tissue. Finally, for lower grade lesions, surgery can be curative, although I don't like to use the word cure because I can't guarantee that, certainly. Obviously, there's a lot of active trials associated with that, and some of that we'll talk about today. And for me, this is what I stress to my trainees, is that more important than size is the location of where the tumors are, because these tumors can be located anywhere along the meninges. Where they are really dictates how we treat them and how we aggressively attack them to help take care of these patients. When we talk about surgery for meningiomas, I think at the outset, you need to understand what the goals are. And this is a conversation that I have with the patients in my clinic when we first meet, or in the hospital when they come in. And so when a patient presents to me with a meningioma, the first thing they hear and the things in the back of their mind is that they have a brain tumor. And although that's true, it's not the same type of brain tumor that people oftentimes will present with. And so my job is to understand where they are, what their understanding of the disease process is, and talk about what our goals are for this process. Many times we can talk about a cure and what that looks like, but I also warn patients that I can't see individual cells in surgery. And so if we're talking about surgery for meningiomas, I can't guarantee that we're going to get every last bit of these tumors out. My goal for surgery oftentimes is to prevent this from ever causing them a problem again. And oftentimes that's what patients are looking for. When we talk about meningiomas, oftentimes they present with symptoms. That's how they came to presentation. And so what we want to do is make sure we we take care of them in a way that alleviates the symptoms that they're presenting with themselves. Many times meningiomas can be on unusual occasions or present unusually, and so many times that diagnosis is required, so we end up doing surgery for that. Although with advanced imaging now, a lot of times we can rule out other forms of pathology by doing things like Dotate scans and understanding what's going on. Tumors that are growing can cause future problems, and so what we talk about is with a growing tumor is preventing future problems for them. And then finally, many times we'll do surgery to decrease the risk of radiation. There are many tumors in locations that we can't do surgery for, or it would be unwise from a patient standpoint and the symptomatic standpoint. And so providing a better radiosurgical target or a radiation target can sometimes be beneficial from a surgery perspective. And that'd be amiss to talk about meningioma surgery without talking about the Simpson grading scale. And this is something that was developed in 1957, and we're still talking about it because it's still relevant. But even in patients who have a Simpson grade 1, there is a significant recurrence rate. And you can see, obviously, if you leave more tumor behind, they're more likely to come back. And so we still refer to this scale because this is something that's dogma in neurosurgery. But at the same time, what do these actually mean? And I think that's a conversation to have. What does it actually mean to macroscopically remove a tumor of the dura and the bone? Well, these tumors can invade the dura along the tract, and that can really require large margins and things like that. So when we talk about meningiomas, oftentimes surgery, in my mind, is the first step in a long series of things that need to be done to make sure we manage these patients correctly. And so when we talk about surgery for symptom relief, this is a classic example. This is a patient who has a left-sided anterior clinoid meningioma who presented with vision loss in his left eye. That is a result of the tumor pushing on that nerve. And so when patients present to us with these problems, the number one thing they want is to get their vision back. At the same time, I can't guarantee that. My number one job is to do what I can to relieve the pressure of that nerve. And as I spend a lot of time talking to patients, explain to them that I can't fix broken things. And so if this nerve is damaged because of this tumor, that vision is not going to be improved. But at the same time, if it's not working normal because of pressure on that nerve itself, then I think we have the opportunity for intervention. And so this patient would benefit from having the tumor taken off that nerve to see if we can improve the vision, and again, try to improve the symptomatology associated with that. How about diagnosis? This is a tumor invading cavernous sinus as well as near the pituitary gland, and sometimes with these types of tumors, it's unclear what exactly we're dealing with. Is this a typical meningioma? Is this a pituitary adenoma? And so sometimes surgery can be beneficial to help get the diagnosis, to get the markers of this tumor to help provide further treatment for them. This is a patient who presented with headaches, and although they didn't have any symptoms yet, this is a fairly large tumor with significant brain compression. And although the patient didn't realize it, they were already having symptoms associated with this in the form of cognitive dysfunction. And so understanding where things are and having conversation with patients about current problems as well as future problems when it comes to these types of tumors is really important, and helping to prevent them is a reason for us to do surgery to take care of these type of problems. Again, and this is a patient with a tubercular meningioma who has optic nerve compression as well as pituitary compression. And I think there's a role for surgery in patients like this to take the tumor away from critical structures to help prevent problems, but ultimately I think radiation is an important part of this. And so anything I can do to help provide for a safe radiosurgical target or radiation target will be beneficial for patients. And so when it comes to surgery for meningiomas, we here apply a multidisciplinary approach where, again, we never use the word cure because we think that these patients are ultimately going to have a lifelong disease process. And despite the best surgery I can't guarantee I can take every last bit of this out. Many of these patients get presented at a tumor board where they're presented in front of neuro-oncologist, radiation specialists, as well as other neurosurgeons to help determine what the best approach is. When we ultimately get to the surgical stand, we talk about surgeries. We try to do what's best for the patient, obviously, and sometimes that involves combined approaches to approach tumors from different avenues. Sometimes that involves staged approaches to try to approach this in a way that makes the most sense. And then ultimately, many of these patients are going to undergo combined treatment modalities. So that may involve surgical resection of these tumors as well as possible radiosurgical treatment or radiation treatment down the road. And so what the point is here is that when it comes to meningioma, it's really a team-based approach. And oftentimes this is something that I think leads to the benefit of patients, and there are advantages and disadvantages. So from an advantage standpoint, we have many different eyes that have different priorities and different tools in their tool bag that can view these patients and really come up with a good treatment plan that makes the most sense for them. The problem with multiple people is that organization can be an issue. Obviously, there's conflicting priorities about what needs to be done. And then finally, there's a learning curve and working with other people that can really cause some problems on their own. But at the end of the day, I really think that teamwork in skull-based surgery and surgery for meningiomas is really something that makes the best for the patients and really allows us to do top-notch works. And again, this has been shown in other areas and it has been shown to really improve patient outcomes when it comes to surgery for meningioma. And when it comes to our team here, you can see the list there. There's a whole bunch of people that are involved with these patients. And it really, again, depends on where the patients are, where the tumor is, where the patient's symptoms are, really helps to determine how we provide for really good long-term outcomes for these people. And so, again, going back to our initial slide, so we have these meningiomas, and the easy answer when it comes to how we're going to treat this patient is we want maximal surgical resection with minimal morbidity. But what does it actually mean? And so for this patient over here who's got a sella and suprasellar meningioma invading multiple compartments, I think when we talk about treatment for this person, it's really about symptom relief and then treatment of this for the symptomatology that they have. I don't think this is a patient who's going to be really eligible for a cure, so to speak, although we can do a lot of work to help improve their symptomatology. Again, this patient with olfactory groove meningioma, they may present with headaches or other kinds of symptoms, but when I talk about treatment for this tumor, there's a real sense of concern for patients who have normal olfactory sensation, because that by removing that and by taking out this tumor, you can sometimes impact their lives in ways that can be unpredictable. So treating these types of tumors really has impacts on people's lives and really understanding of where the goals of surgery are. And so traditional approaches for meningioma involves large craniotomy. This is a patient we did a bifrontal craniotomy on for olfactory groove meningioma. And this is really the classic approach that people do to approach these types of tumors. It's not without morbidity. You can see there's a large incision, a large exposure of the bone there. And people can have complications associated with this. But historically, this has been a very good way to take care of some of these problems. This is another view. This is a patient that had really tubercular meningioma. And this is the view you get from a microscopic transcranial approach. This is from a pterional approach. You can see from the side that we're looking at the optic nerves, optic chiasm, and you can see the tumor down here. And this gets us a really good approach, but again, with a lot of things at risk, including there's a retractor on the brain here, splitting the sylvian fissure to expose this all. And although the surgery here can be done very successfully without significant morbidity, there are significant opportunities for problems during these types of approaches. And so although this has been a very good way to approach these problems, our job as surgeons is to try to figure out better ways to take care of these kind of problems over time. Again, a pterional approach here. Here we've taken off the orbit. You can see here's the periorbital of the orbit, frontal lobe, temporal lobe, and this is really the classic way we approach these type of problems to really get to these types of tumors. And here's a craniopharyngioma between the optic nerves. And you can see, although surgery can be done safely here, you really have things that are at risk that could potentially cause problems for patients' morbidity down the road. And so over time, what we've developed is what I like to call minimal access surgery. It's not truly minimally invasive surgery because we're still being maximally invasive to try to retract these tumors. What we're doing, however, is limiting our risk associated with these and limiting potential structures that may be at risk associated with this. And I know Dr. Agi is going to talk later on about some specific minimally invasive approaches, but I'd like to talk a little bit about what we do here and some of our approaches for them. There's a lot of different ways we approach tumors now, again, with a goal not necessarily of curing them, but really of preventing problems in the future and preventing this from causing them a problem ever again. My classic approach, the thing I like to do the most, is the endoscopic endonasal. I think this provides for minimal morbidity and possibly maximal surgical resection with really, I think, an improvement in some of the things we've done in the past. We do transorbital surgeries. There's a lot of different variations to this, and I won't get into the details. But what we're learning is that 20 years ago, the classic approaches for meningioma involved large craniotomies, resection of large amounts of bone. And as we move forward, we're finding that some of these more minimal access surgeries really can accomplish the same goal with decreasing morbidity associated with that. And so I'll first talk about orbital approaches. This is one of the things that I do with my oculoplastic surgeon quite frequently, probably about once a week we'll employ this method. And what we do is we use the body's natural creases around their orbit to get to the anterior and middle cranial fossas. What this does is allows us to make smaller approaches to resect large tumors. And ultimately what ends up happening is that patients end up doing better, going home quicker, and really recovering quite nicely. So I'll start with this. This is a Anti-Clino Meningioma that we took care of about 3 weeks ago or so. This is a patient presenting again with vision problems. Again, the traditional approaches involves a craniotomy coming through the sylvian fissure to get to where this tumor is. And unfortunately, we were able to approach this and resect this actually through the orbital approach. And I'll show you that here in a second. This is our classic incision. This is what's called Transpal Pebble incision. My oculoplastics team does the initial approach. Here we're going through the skin to expose more of where things are, gently dissecting. Here we're opening up to the supraoral rim. He's dissecting the periorbital away, getting us access to the corridor that we want to access. Ultimately, we elevate the pericranium here, which we'll use for closure. Here we're elevating the temporalis muscle to really get good exposure where things are. We use cautery to separate the fascia of the temporalis muscle. And ultimately what we're going to do is expose all this bone, and this bone's going to be removed. We oftentimes do these cuts using the sonopet. Here we're making a cut in the bone, which allows us to, again, resect it from a minimal damage perspective. And this allows us to put things back together with a really good cosmetic result. We make a burr hole here to expose underlying dura. Once this is done, we complete the craniotomy using different techniques. Here we're using the craniotome to complete our frontal craniotomy. All through that small incision in the bleph. Here we're breaking off the bone and removing it in its entirety. And now we're doing the epidural dissection. It turns out that this approach, although it's more minimally invasive, so to speak, it's really kind of the same access you would get if you were doing a classic transorbital approach. As we dissect further down more, we're doing the extradural dissection, and this allows us, they're removing the clinoid. Finally, when we get everything devascularized, we access intracranial compartment. Here we're going subfrontally in the epidural plane to ultimately discover where the tumor is. You can start to see the tumor there. Once we decompress the brain and allow CSF to brain off, you can see that things get quite relaxed. Again, more access to the tumor. And this allows us to continue to work around this area. And at the end of the day, as I said before, it's really not much different than our normal access. It just allows more opportunity for healing. Here we're dissecting away the optic nerves in the middle cerebral artery. By separating these tumors from these structures, we really have enough work to work. Here now we're following the ACA again to identify different structures. Once we identify the structures, the real work begins by debulking this tumor. Here we're separating it from the brain parenchyma around it. Again, identifying those structures. And once you identify those skull-based structures, the rest of the surgery really becomes quite simple, and just like any other open craniotomy would. Jumping forward here, debulking, and at the end of the day, this is what you look at. This is the patient post-operatively about 6 weeks, and you can hardly tell that he had surgery. And so I think these type of interventions allow us to do more. Here's another patient who has an olfactory groove meningioma that you'll see here. Again, these types of tumors, traditional approaches involve the bichrome incision, taking off the frontal bone to get where this is. But as is shown here, oops, as is shown here, this tumor is invading into the nose. And so any open approach is going to potentially leave that tumor behind. And so what we tend to do is favor endonasal approach for these types of tumors, because what that gets us is that gets us access to the tumor itself by devascularizing it first, and really taking away the blood supply as well as the involved bone to get us where we need to get to make sure we remove this tumor. Here we're internally debulking the tumor to remove again, more of it, just like you would do from any transcranial approach. Ultimately, we're able to get a good resection of this, separating it. Here, we're working on the inside of things. And then finally, working around it, just like you would do for a normal transmicroscopic work. And at the end of the case, this is what we're looking at. The brain parenchyma is there. You can see the subdural cavity is nicely decompressed. There's no problems associated with brain edema. And we really don't see the brain until the very end of the case. And this is a very good way to approach these types of tumors and get really excellent surgical results. And so here you can see from our patient that really there's no signs of residual tumor, and he did quite well from this. The drawback associated with these types of approaches is that you have a problem with potential wound healing issues and CSF leak, and we've gotten much better over time with that as well. And so I think that some of these more minimally access approaches for these types of tumors really allows us to do better work from a surgical perspective. And so this is a different tumor. This is a patient who presented again with really headaches more than anything, although you can see this tumor is in contact with a lot of different structures of the anterocranial fossa. And this is a patient who you really have to have a conversation about, because when it comes to accessing this area, you know, as I've described already, there's 3 different ways to get to this point. Way number 1 is that bifrontal craniotomy, which would get us wide exposure for this for a good resection. But the other 2 options, including a transoral approach as well as endonasal approach. And so how do we approach this tumor really depends on the patient. And this is the conversations that I have with these patients in clinic, is trying to figure out what's important to them. Do they really want you know, a big surgery, or are they willing to undergo minimally invasive surgery through the nose? But the drawback associated with that is the risk of sense of smell and taste, because we know that doing through the nose, the chances of saving smell and taste are quite low. And so if this patient's a baker or a cook for a living, and I risk their sense of smell and taste by doing surgery, I think that I do them a disservice if they can't do that afterwards. And so then we may talk about a more transcranial approach for resection of this, where I can have a chance to try to save some of those functions to help improve their lives afterwards. And I think you know, as I said earlier, the treatment really depends on the patient and where the tumor is, and understanding those kind of things, understanding where the patient is and where they're coming from and what their goals and expectations are, helps to drive where we go from this and how we treat the specific type of problem. I think that when it comes to all the tools that we have, it's really important for surgeons to be able to employ many different modalities to help take care of these kind of things, because there are a lot of different ways to get these areas, and our number 1 job is to decrease morbidity at the same time, again, resecting as much of this tumor as possible. And so although we can do some minimally invasive things, there's still a role for obviously open transcranial surgery. There's no way for us to get to this type of tumor without doing a transcranial approach or a craniotomy, just based on where it is. And so even though we have a lot of tools in our tool bag, we still have a lot of ways to go to try to help take care of these patients and find out better ways to take care of people. And then finally, in summation, collaboration and teamwork in our team here at the Medical College of Wisconsin has really led to better patient outcomes when it comes to meningioma. And again, despite the fact that we have a lot of really interesting tools in our tool bag, the tumor itself decides how we take care of it, and not our choices ourselves. And so we let the tumors and the patients kind of guide our process as we go through that. And with that, I will end. Thank you guys again very much. It was appreciate this opportunity to talk about something that I love dearly, and that's my family there. So I don't know if you're taking questions now, Joe, or what you're planning on doing.
Yeah, Nate, thank you so much. That was just a great talk. Wonderful introduction to the day. Just a brief housekeeping question for our attendees. There should be a Q&A button on the lower right-hand corner of your WebEx screen. During all of the presentations today, please feel free to submit those questions, and we will answer those in order. We do have some time for some questions, so if the attendees would like to submit those, please feel free to do so. Nate, I do have a question for you. It's fantastic the advances that have been made with regard to some of these minimally invasive approaches. Can you discuss a little bit, and maybe they're too new to even have data on this, but with regard to the opportunity for a gross total resection from some of these approaches versus subtotal resection compared to an open approach? Because especially, I guess the question is, do those open up the opportunity for introducing, more multimodality treatment opportunities, so surgery followed by radiation therapy? Can you discuss that a little bit?
Yeah, and I think that's a great point. And I think, everyone's going to kind of look at this in different perspectives. The way I view these types of things is, like I said earlier, I don't use the word cure in my patients. I never use that, because I think that it's impossible to know that. That being said, I go into every case thinking I'm going to try to take out the whole thing so we don't need anything further down the road. I think with the advances that we know from a treatment perspective, it's always nice to know that I have something to back me up from a surgical perspective. And so, we can do, large surgeries, take out whole tumors and do great things. But what it ends up happening is we increase the risk associated with that. So doing a large craniotomy with exposure of all the different structures opens up the potential for things like cerebral edema or stroke associated with brain injury, or injury to the optic nerves or carotid arteries and things like that. I think that as we get better from a minimal access perspective, and as we understand the anatomy more, which we are doing, I think a lot of ways the surgical resections are equivalent to the large open craniotomies. Certainly when it comes to anterior craniofossa meningioma, where you can remove all that bone on the way in, you're doing that better than a lot of the open craniotomy people have done historically. But again, I think it's all about the surgeon and the technique. I think, in my mind, knowing if I have to leave a little bit tumor behind because it's either stuck to something, or I think it's going to increase the risk, and knowing that radiation is an option for the patient down the road, I think that allows us, again, to really try to get these people back to their lives as quickly as possible, while decreasing the time they're spending in the hospital or recovering from these type of surgeries. And we've seen that in our practice. I mean, I think since we started employing these techniques, our average hospital stay has gone from about 5 days to about 1.5 days with these. And that really allows patients to get back to their lives normally. Our biggest problem right now is that the patients, they look in the mirror after surgery and they realize that, they look normal, and so they want to get back to normal things, and so they try to rush things back, but they don't realize that they had a giant operation. They just don't look like it.
I think that's a great point to make as well. Yeah, I mean, the recovery obviously from these minimally invasive procedures is certainly a reason to keep on doing them. That's great. Thank you so much, Nate.
You're very welcome, Joe. Thanks again for this opportunity.
Yeah, for sure. Any other questions from our panelists, or any other questions from, I don't see any questions from the participants, but.
I would like to say that was a great talk, Dr. Swagerman, and I really like the thoughtful approach. It's very important, like you said, to not use the word cure. I feel like traditionally we've used the word a lot, and even grade 1 have recurrence rate. It's not 0 with gross total resection, or what we used to call gross total resection. So I think it's very important to get the message to patients. And these minimally invasive approaches are great. As Dr. Bovi mentioned, they bring the opportunity of multimodal treatment sometimes, because you do leave tumor behind. Sometimes the access does become limited. What I would want you to talk a little, the minimally invasive, although when everything goes great, they go great in a day and a half of stay, but they do have their own sets of complications that happens, and it does have a learning curve. So for our learners here, if you want to touch base a little bit on that aspect and the training that goes behind, and when to use this approach, because it's a fancy term everybody wants to use, minimally invasive, but in brain surgery world, there's nothing minimal about any of these, because they all have their own set of complications.
Yeah, and I think you're exactly right. I think, I don't like that term minimally invasive, because this is not minimally invasive surgery. It's still maximally invasive surgery, but what it is minimal access. And so what you're doing is minimalizing your ability, your opening, but you're still doing a big surgery. So, understanding these techniques, it takes time. It takes time. And I think, when I was learning these kind of things, I'd spend hours and hours in the lab understanding the anatomy, because the only way you're going to understand how to get to places is understanding the anatomy that's around the structures. And yeah, you can understand that, from doing in surgery, but in order to master these types of things, you really need to spend time in the cadaver lab, really dissecting out where you're trying to get to, how much access you can have, and understanding where you can and can't go for these types of things. When you minimize your access, you really have to be right when it comes to what you're planning on doing, because if you're wrong, you really limit your ability to do surgery. So I think you're exactly right. For people who want to learn how to do these kind of things, this takes time, and it takes effort to try to do that. And you're absolutely right. When they have their own sets of complications, nothing's free. And many times, as you said, if things go great, they go great. But if there's a problem, if I have a carotid injury through one of these minimal access, you have to be able to manage that through a minimal access, which becomes its own set of problems. And so, as it comes to all surgery, the real learning curve is managing complications. And so, you can only do that with repetition and understanding and confidence, knowing that if something goes wrong, can you fix it, or prevent it from getting worse? And I think those kind of things take experience, they take time. It's taken time in our practice here. I think that, our first year here, we did 9 transorbital surgeries, because you're really selective about the cases you choose. And as the learners here, as they go and practice, you're not going to want to tackle that anterior clino meningioma through a transorbital approach. It's just not going to be feasible, because you're not ready yet. But over time, this last year we did about 40 transorbital surgeries. And so you get more confident, you get more selective, you understand where the boundaries are, and you understand how to employ these tactics more beneficially. Same thing with endonasal surgery. Advancing from a pituitary tumor to an olfactory groove meningioma, that's not a small step. That's a giant step with a significant increase in morbidity if you're not prepared to deal with that or understand how to heal that, fix that problem. And so, like everything else, it's a stepwise gradation. And as you get more confident, understand the pathology, understand the anatomy, understand the healing process, that allows you to do better surgery and employ these techniques more. But coming out of the gate, no one should be doing these kind of things unless they're absolutely ready and they've done some significant time in the lab and understanding things.
It's fantastic, Nate. Hey, thanks again so much, and thanks for kicking off our talks today. That was a perfect entryway into the remainder of this talk. So thanks again.
Thanks again, Joe. Thank you, Dr. Dey. Really appreciate this fantastic forum, and look forward to hearing the rest of the speakers.
All right, good stuff. Well, we're right on time. And our next presenter, I'm very excited to hear speak. Dr. Palmer is a radiation oncologist at the Ohio State University James Cancer Center. He's a specialist in the treatment of brain and spine tumors there. And I've really gotten to know Josh well as a friend and colleague. We've had the opportunity to do a lot of collaborative work and multiple manuscripts and grants, in addition to some international clinical trials that we're both involved with through the Alliance and Nrg, focusing on both primary and secondary malignancies of the brain and spine. So I'm very excited to hear his talk today. I think we're going to learn a lot. It's a perfect segue from Dr. Swagerman's excellent talk. So Josh, the stage is yours, and you should have an opportunity to share your screen.
Perfect. Can you guys see the screen and hear and see me?
Yep, we can see your slides and we can hear you. So we're in good shape.
Perfect. Thank you, everybody, and thank you to the organizers. Thanks, Dr. Bovi, for that great introduction. It's going to be great to kind of learn from everybody today. So what I'll be going over today is some advancements in radiation treatment planning for patients with meningioma. Also cover a couple of other rarer histologies in the skull base, but focus mostly on meningioma management. So these are my disclosures. I don't have any disclosures for the current talk. So we'll go over some background, talk about the advancements in PET and how it's impacting meningioma treatment, some of the implications on surgery and radiation, some key cases that I think illustrate the utility, and then some future role for sort of theranostic medications. So like we mentioned before, just briefly, meningiomas are a relatively common brain tumor, and we're starting to see more as the WHO changes, more higher grade tumors, but the grade 1 benign tumors are still the most common. Typically, the diagnosis and follow-up is done with CT or MRI imaging, so structural imaging, but there are limitations to structural imaging to delineate tumor, especially as a radiation oncologist, with areas that have some osseous disease, what's the true extent of osseous disease, areas of the skull base and neurovascular structures, and especially for patients that are commonly, these patients have some form of surgery, post-radiation or post-surgery changes can be quite difficult in terms of trying to fully understand and delineate the tumor. And just as an aside, we have a few publications, but one hopefully upcoming, showing that non-malignant tumors seem to be more common in certain areas of the US. And we're showing that areas that are high radon, high particulate pollution, like the Rust Belt, seem to have a higher incidence of meningiomas. And so just highlighting the kind of Wisconsin, Ohio connection there. And so the difficult locations of tumor are typically the ones that benefit the most from PET imaging. So parasagittal locations, cavernous sinus, the CP angle, sphenoid wing, foramen magnum. These are typically the types of tumors that make it to the radiation oncologist because they may or may not be completely resectable. Typically, the anatomical imaging that we get done first is a CT of the head, demonstrating this sort of homogeneous contrast enhancement. And on anatomical MRI imaging, you can see axial T1 contrast showing an intense uptake with homogeneous enhancement for majority of patients. This one's heterogeneous. And axial T2 usually shows an iso-intense mass. And then standardly for treatment planning, right now we use sort of the 0539 published studies as the gold standard, as it's our main American prospective study to delineate the tumor using MRI is the standard currently, where we use pre and post imaging volumetric scans, as well as the T2 and FLAIR imaging to delineate the tumor and its extent, both intraosseous and whatever's residual in the tumor resection bed. Typically, and this is based on the 0539 study, we don't include cerebral edema or the dural tail. And then hyperostotic bone is included. And then based on low, intermediate, or high risk, based on the criteria from 0539, there's a different CTV margin and then a PTV. Now, as a disclaimer, PET imaging for meningioma is not currently FDA approved. The Gallium 68 dotate PETs that I'll be mostly covering today is a FDA approved for high-grade neuroendocrine gastric cancers. So there's a relatively limited FDA approval, but it is quite useful for other disorders, and we'll be highlighting some of the not FDA approved areas. And so the typical tracer that many are used to is the FDG glucose PET, and it's most widely used. It has a half-life of 110 minutes. The challenge with meningiomas is that it's a typically slow-growing tumor, so the glucose metabolism is not very high, and so it's not significantly elevated amongst the background. And the background, the brain, has an extremely high level of glucose metabolism, so there's a very low tumor to background ratio. There's also the issue with surgical or reactive inflammation changes that can also make it quite difficult to actually utilize a PET image in these situations. So there's low sensitivity with a typical PET tracer. Somatostatin receptor ligand PET tracers like a gallium dotate PET. There's also gallium dotatate and dotanok. These all have good and similar kinetics in the brain, but the gallium dotate has a higher tumor uptake ratio, suggesting that it has a better diagnostic value. And meningiomas, like neuroendocrine tumors, so you can almost think of them as part of the family, express highly the somatostatin receptor 2, which this ligand goes after. There are other PET imaging tracers that some in places around the world, like in Heidelberg, will use for meningiomas. The MET-PET, FET-PETs, and then other lesser used for at least meningiomas. The utility of a FET-PET is also quite interesting because it can be used for intracellular invasion, because unlike the MET-PET and gallium tracers, the FET-PET has very little uptake in the pituitary gland, so intracellular invasion of tumor can be easier to delineate because the pituitary gland, for at least gallium, 68 dotates have high uptake in the pituitary gland. And so this is just a comparison. So the FET-PET's in the middle, gallium dotate or dotatate in this situation is on the left with a contrast enhancing kind of the standard imaging on the right. You can see the intense uptake in the tumor. And then this is a little difficult because there's likely some pituitary uptake somewhere in the tumor, but you can see that the tumor itself is the FET-PET abnormality. So gallium dotate imaging, kind of going into it further, like I said, somatostatin receptor 2 is highly expressed in meningiomas, nearly all. It's a positron emitter with a half-life of 68 minutes, does not require an in-house cyclotron, so that can obviously be quite difficult, and many of the other PET tracers that are more advanced do require, with such short half-lives, an in-house cyclotron. Excellent target to background contrast due to the lack of bone and no normal brain uptake, typically. There is a positive control in the pituitary gland. It's highly sensitive with a positive predictive value of 89% for meningiomas. For diagnostic purposes, there's a differential, and so I'm listing here some of the other things that can also pick this up. It's important to know this as you're using dotate imaging, that it's not specific only to meningioma. There's also a lot of other tumor types that can pick up SSTR uptake, but it can aid in decision making. So this is just an example of one of my patients that we had an incidental tumor found on the PET imaging. He had a solitary fibrous tumor, which some would have previously not thought would have PET uptake. So this tumor was initially resected with our neurosurgeon, Dr. Lonzer, quite a long time ago, and started to progress, was felt to not be resectable given its cavernous sinus location safely. And so we ended up getting a PET scan and then using it for radiation. But what we found on his PET scan, he had no symptoms of this, were 2 foci in the pancreas that were also hyperavid. So after we finished his radiation treatment, he ended up going for a distal pancreatectomy robotically and lymph node resection, and he was found to have 2 separate foci, just like the PET shows, within of a pancreatic low-grade neuroendocrine tumor. So hopefully will be durably controlled now. What I'm highlighting here is that the Ki-67 of his solitary fibrous tumor in his brain was 1.5%. The Ki-67 for the more bright tumor, the one in the body, was about 2%, and then the one in the tail was 1.2. And you can see that the intensity is about the same between the brain and the tail lesion and was low, but the body lesion was much higher. And you know, the Ki-67 was approximately 50 to 50% higher or 100% higher compared to the other two lesions. And at least in our series of about a little over 70 patients, we found about 3% of patients do have incidental tumors found when we're getting the PET scan. So, and then getting worked up and trying to help these patients sort through what it is. So I have two other patients similar to this that are going through the same issue with meningioma. And so this is an example of a metastatic esthesioneuroblastoma that also shows intense uptake. This patient ended up having disease almost everywhere. We treated sort of his dural sinuses because he had sort of spotted disease kind of throughout the dural sinus, the sagittal sinus, I should say. We also treated L3 through the sacrum with palliative radiation. What you can see here is that the lumbar spine and sacrum uptake was significantly diminished compared to his other areas of disease that had not been treated. This is an example of a glomus tumor, or what's now called a jugular tympanic paraganglioma, on a gallium dotate PET. There was some discussion, and after surgical resection, there was felt to be some potential either postoperative changes or thrombus left at the surgical entry site, not known to be tumor, but the PET scan does demonstrate that that area was residual disease left in the surgical entry site. And then there's also some difficulty with these glomus tumors, and I like them particularly for this disease entity, because you can see in the skull base, it's quite difficult, even with T1 pre and post contrast imaging, to delineate with all the vascular structures, even on fat saturation, where exactly in the skull base or foramen magnum area the disease tracks, or especially if it tracks into the infratemporal fossa or into the facial structures. And so the PET scan, you can see, highlights it extremely well, has really improved my ability to treat these patients. And then this is an additional example of a patient we treated, and another patient, histology at least, that in the literature was unknown whether hemangiopericitomas had good uptake, low-grade ones. And so this is a grade 1 hemangiopericitoma that we treated with radiosurgery, and you can see the PET improvement. So the PET uptake decreases significantly, and as well as the size of the lesion on MRI, which is about 6 months post-treatment. So it helps with tumor grading, like I highlighted in that case, that the gallium dotate uptake may correlate with grade. It can also help with tumor extent. And so I showed a few examples, and I'll show a few more, that there are difficult situations that come up clinically trying to understand exactly where the tumor is. And it does show superior tumor delineation in a number of studies compared to just normal contrast enhancing MRI alone. So we found, at least in our data as well, that it's more precise than just the MRI. Tumors can have some discordance, especially in the areas that I've listed here, and I'll show some examples. And so this is an example that was published by Galdiks in neuro-oncology, that you can see there are areas on MRI on these three panels were very difficult to delineate, but on the PET scan, you can actually see there's intense uptake that's not visualized on the MRI. We'll kind of go off tangent just a second for surgery. We haven't yet done this in our patients, at least, but it can be used for surgical planning and extensive surgery. There is the potential theoretical ability to detect intraoperatively the gallium dotate tracer to determine if a tumor has been completely resected. And then some of the areas that we have used it in is to confirm a gross total resection for a higher grade tumor. So this is just an example of the PET uptake for a large skull base tumor. And then highlighting some of the more difficult situations clinically. So for a grade 2 meningioma, this was called as a gross totally resected tumor on MRI. The PET scan for this individual showed no tracer uptake. This patient's now out 4 years and has yet to have any recurrence. This is a similar patient, had a gross totally resected tumor based on MRI, opted for observation. You can see that there's focal tracer uptake at the cribriform plate. And for this particular patient, was followed for several years, was very against doing radiation, ended up having a MRI, and we repeated the PET. The PET avidity increased in this area, demonstrating an actual focal recurrence. And now the patient underwent radiation. This is an additional patient that went on to a clinical trial that also had a postoperative MRI that was read and confirmed as no residual tumor. There were 2 areas of focal uptake, both in the supraclinoid region and the sphenoid region. This patient was treated with radiation or randomized to the radiation treatment and is yet to have a recurrence. Just showing both areas. And so for treatment planning, at least where I think it's most useful is the delineation of difficult tumor locations for bone invasion or dural involvement post-surgery to differentiate reactive changes. There's lots of experience, and including our own, showing improved intra-observer variability for patients because MRI can be so difficult between different people with different experience and radiologists versus radiation oncologists, but the PET scans quite improves that quite a bit. And it may help decrease the radiation dose to organs at risk. And so for tumor discrimination, you can see here that there's an area on the right sort of cavernous Meckel's region that was not seen well in the MRI. And so for patients like I've treated, this is a patient that we went back with our neuroradiologist. We really couldn't see anything in this region on the CT and MRI, but you can see quite clearly that there's an area on the PET scan for this patient that was read to have a gross totally resected grade 2 tumor. This patient ended up getting radiation and has yet to recur. And so this is highlighting one of our patients now 3 years out, had a recurrent grade 3 meningioma, had radiation, 2 surgeries, and then recurred, then saw us. Got a Dotate PET image, which I'm showing here. I ended up giving 40 gray in 10 fractions, SIB'd with a 35 in gray, for the 35 gray and 10 is the yellow, to the postoperative area, but the boost was given to the Dotate area. And so for these really difficult tumors, it's very difficult to get a multiply recurrent grade 3 tumor to respond well, but this patient's now out 3 years with no necrosis or recurrence, having had his first recurrence within the first year. And so the clinical implications is that you can increase the sensitivity of differentiating scar versus tumor, and for tumors that are going into bone. This is an example of a patient that it's difficult to understand if they had a recurrence into the orbit, and the PET scan does help to differentiate that. And Gina in Cornell has demonstrated some nice work that shows that you can really use dynamic PET imaging to differentiate scar versus true tumor. This is Stephanie Combs's group from Germany, showing that their large cohort, this is not just Dotate PETs, it's all the PET imaging for meningiomas, that utilizing PET imaging to treat these patients not only increases the local control of the tumor, but also increase the survival for these patients. So highlighting how important it is that we consider using PET scans for difficult locations. And they highlight in their report how often they had to change their radiation volumes due to the PET being performed. And then Dr. Mark Mishra, another colleague of mine, published a paper showing, like I highlighted in the case earlier, that PET imaging can change post-treatment and tends to decrease for patients that are responding. And then this is our recent publication that came out this week, demonstrating the precision that PET imaging can provide. And we found that there was a significant difference in the MRI delineated versus PET delineated blinded volume contouring, as well as identifying approximately 30% of patients having new areas not seen on the MRI contoured on the PET, highlighting potentially reasons for treatment failures. This is a couple of the patients from our study demonstrating areas that were not delineated on the MRI that were delineated on the PET. And then this is an example of a optic nerve sheath meningioma that both our radiologist and I did not realize that there was tumor hidden in the sella. This is is a optic nerve sheath meningioma. So typically we cover the optic nerve back to the chiasm here, but what you're seeing is a separate foci in the sella adjacent to the pituitary gland, and so we ended up covering that. And so this is a summary slide demonstrating the current clinical indications for utilizing PET imaging for patients with meningioma. and how we integrate Dotate PET imaging at OSU. Currently, we use this for all of our patients, and we require for definitive patients, we do it with the planning MRI, and we coordinate it with the CT simulation. For postoperative patients, like I highlighted, it's not 100% specific to just meningiomas. Acute inflammation can also have some mild uptake. And so I've started to do the PET imaging, trying to get it closer to months post-surgery. And for patients that can wait, like a gross totally resected grade 2 tumor, I often try to do 3 to 6 months later when we start to plan the MRI to allow for normal brain to relax and for the sort of uptake to hopefully die down from inflammation and surgical healing. We use the MRI and Dotate PET and we fuse it, and we use the MRI standardly for the gross total or gross tumor volume delineation, but then we modify the GTV utilizing the PET activity. Currently, we use an SUV uptake at or above the superior sagittal sinus as sort of the low end, and then the CTV is based on grade. The future areas that I'm excited about, that I'm interested to see over the next 3 to 5 years, are several studies that are accruing meningioma, progressive meningioma patients throughout the U.S. Using lutetium-177 or Lutathera, which is a beta emitter, hopefully honing to the tumor. We also, and I'm the radiation oncology chair for the CONNECT study at the bottom, where we're going to include pediatric and young adults that have refractory brain tumors that have SSTR receptor 2A that demonstrate uptake on Dotate PET can also receive Lutathera. And then an exciting area that I'm personally interested in is for those patients that are refractory to Lutathera with gastric or pancreatic neuroendocrine tumors. There's early studies looking at actinium-225, which is an alpha emitter, so on high LET sort of radiation that will hone to these diseases. The early sort of data is showing that for even these progressive tumors that have failed through Lutathera, there's a 63% partial response rate, and at least in some of the early studies, there have been no progressions and a significant decrease in plasma levels of chromogranin. So something that I'm really interested to see as we learn more, to see if this is something we can bring to our meningioma patients. So current limitations, unfortunately, the PET imaging is not FDA approved. And so this is a patient-specific, probably regionally specific imaging that you'll have to discuss with patients, whether or not it's worth getting, as well as work with payers to help cover. So right now we're limited to retrospective series, and hopefully in the future we'll have prospective data. And I'm highlighting here one of the studies that we'll hopefully have over the coming years, utilizing intermediate and high risk meningiomas, trying to interdigitate PET imaging to help both delineate tumor but also monitor response. And so in conclusion, when compared to contrast enhancing MRIs, PET imaging does add clinically valuable additional information. It's most relevant for difficult locations or for situations where you think that tumor may be under-visualized on typical anatomical imaging, but future validation using large multi-center studies is needed. And so thank you very much, and I'll take any questions. And this is my son enjoying Earth Day with his grandmother. Thank you very much.
Josh, that was just great. Thank you so much for that amazing talk. It's really so wonderful to see kind of a modern imaging approach being employed for these meningiomas, and not just meningiomas, even the other tumor examples that you had pointed out. I think there's a lot of promise ahead, especially with regard to surgical planning in our particular field, radiation planning for these meningiomas. I think this is going to be a real game changer, and it's kind of fun to see this come into play at the ground floor. It's fantastic. We're going to hold questions until our panel discussion just to stay on track with time. So Dr. Palmer, thanks so much for your chat. Please stay on, and we'll take some questions in the panel discussion at the end. Okay.
Thank you. Will do.
No, thank you. That was great. All right. Again, super excited to introduce one of my other colleagues. Rupesh Kotecha is Chief of Radiosurgery and Director of Central Nervous System Metastases at Baptist Health down in Florida. He attended medical school at Michigan State University, followed by his residency at Cleveland Clinic, actually. He has extensive expertise in the treatment of all benign and malignant intracranial disease processes, and really brings a unique focus with regard to radiosurgery and proton beam therapy. Really excited to hear his talk today, and will be a nice segue from Josh's talk with regard to kind of advances in imaging planning to moving those concepts into actual treatment. So Rupesh, thank you so much for joining us this morning from Florida, and we appreciate you and looking forward to your talk.
Well, thanks so much for that kind introduction and for having me here today. And hopefully I'll integrate some of the concepts that Josh went over into how we do radiation planning as we move to proton therapy. So these are the disclosures for my talk today. Obviously, we'll discuss radiation technology here. So first, I wanted to go through an introduction as to how we think about managing meningiomas with fractionated radiation therapy. We'll go through some of the current clinical indications, and that will lead into how we think about radiation planning considerations for this patient population. Now, we'll review some of the dosimetric advantages of proton therapy over photon therapy, and then hopefully that will lead into some of the dosimetric to clinical translation work that has been done. And then we'll review some of the limited published clinical outcomes with proton therapy, and then dive into the ongoing particle therapy clinical trials that are in process. So I think it's always important to note that when we think about treatment for patients with meningiomas, despite the prevalence of this tumor type, most of our decisions are actually based on these four principles here: clinical judgment, personal experience, institutional tradition, and then retrospective and very select prospective series. So as you've heard earlier today and throughout the rest of the talks, there'll be really an absence of level 1 evidence to support most of our current management paradigms for this patient population. And so I think going forward, we really have to develop prospective evidence to really better serve our patient population. Now, for those who have benign or WHO grade 1 meningiomas, typically these patients receive radiosurgery or stereotactic radiation therapy if they're not going to have surgery. And really our evidence for that recommendation is limited to level 3 evidence, and that was based on the most recent ISRS review of the literature. From our standpoint, with regards to proton therapy, the guidelines are actually pending at this time and hopefully will be actually finalized later this year. Given the reduced prevalence and then changes in WHO grading criteria over time, as well as the heterogeneous patient selection, the data on radiosurgery, stereotactic radiation therapy, or even particle therapy for those higher grade meningiomas, WHO grade 2 or 3, remain limited at this time though. Now for WHO grade 1 meningiomas, definitive radiation therapy, whether it's radiosurgery or fractionated radiation therapy, including proton therapy, is typically used for those patients who are medically inoperable, those who have tumors in challenging locations, for example, the optic pathway meningiomas, or even those with recurrent disease after prior surgery. But we're also learning that there are patients with WHO grade 1 meningiomas who may be at higher risk for tumor recurrence. This, for example, is the 10-year experience at UCSF from one of my colleagues, now Dr. McDermott. And there are some features now that predict potentially for patients to have a higher risk of recurrence, for example, MIB1 in this series. And there are newer kind of integrated molecular prognostication schemes that are being developed. And we may identify some of those patients who may need fractionated radiation therapy up front. For WHO grade 2 meningiomas after a gross total resection, adjuvant postoperative fractionated radiation therapy is associated with favorable control rates. The R2G0539 as well as the EORTC trial both had 3-year progression-free survival rates at about 90% or higher. But it's important to note that neither of these trials included patients who were treated with proton therapy. Now, there are some data that suggest favorable control rates after having a gross total resection of a WHO grade 2 meningioma that in which patients have an MRI confirmed resection extents. Now, whether we also use PET dotate to confirm that or not is probably something that we'll bring up in the panel discussion. But this has really prompted further prospective evidence development in this space. And there are two actually ongoing trials, the Nrg Bn003 trial, I think as of last week, probably accrued 111 out of the 133 patients. This trial does include proton therapy, but I believe it's something like a single-digit number of patients actually being treated with that. And so we won't get a lot of prospective evidence and not really any comparative ability between IMRT and proton therapy. The Rome EORTC trial also recently completed its accrual, I think at the end of last year, but we're unsure how many of those patients, if any, actually receive proton therapy. So we're going to be limited in our ability to make prospective decisions for these patients as well. Now, for those patients who have recurrent WHO grade 2 or 3 meningiomas, subtotally resected WHO grade 2 meningiomas, or newly diagnosed WHO grade 3 meningiomas, radiotherapy is essentially routinely recommended after maximal resection. Here is the high-risk cohort from RTOG 0539. Essentially, the 5-year PFS was about 50%. And it was actually worse, although they're small numbers, for those who had recurrent grade 2 than newly diagnosed grade 3 meningiomas. And again, none of these patients were treated with proton therapy. So this is the workflow that we have at our institution for patients being treated with radiation therapy. So again, at diagnosis, typically of an MRI-defined lesion, if the patient's going to receive radiation therapy, and increasingly as well for those complex meningiomas that are undergoing resection, we are trying to obtain a dotate scan as well. I think it's something that Josh had mentioned, it's regionally dependent, and I've seen vast changes between just even last year and this year with our ability to try and obtain these scans. We also obtain prospective neurocognitive assessments in these patients. It will hopefully help to build our evidence base for treating these patients with advanced radiation. And then we also obtain meningioma-specific quality of life assessments. I think Dr. McDermott, one of my colleagues, will speak on this at the end of the day. Then patients are planned for radiation therapy, and then follow-up scans that I see in clinic. So we're going to just focus on the radiation planning aspect today. So these are the radiation therapy technologies that I have to choose from for patients when I see them in the clinic with meningiomas, and a number of these machines can be used. We have conventional linear accelerators, sometimes actually do fractionated stereotactic radiation therapy with the CyberKnife. Even if I'm giving 54 gray, sometimes the dose distribution is more favorable. You can use, for example, Radixact tomotherapy, Gamma Knife for single or multi-session radiosurgery. With regards to MR linear accelerators, I think this is going to be an interesting space going forward, given that the brain tumor packages are going to be released for some of these machines later this year. We also have a prospective registry for patients to receive brachytherapy. Typically, we triage this for recurrent patients. And then obviously we'll talk about proton therapy here today. We also have a prospective multidisciplinary peer review process that goes through all of the patients and the technology triage process. When we actually first looked at this for 500 consecutive patients that went through this, for those who received IMRT or SRS or SBRT, about 1 in 4 patients has it changed as a result of this prospective peer review. And we're actually looking at the data right now for those patients who then get triaged to proton therapy. And if you're actually seeing a patient in clinic and you determine that you can use more than one machine to treat a patient, or you're in between treating a patient across a variety of platforms, or if a patient actually walks in the door and wants a particular machine because of branding, and you may think that they would be benefiting from a different machine, you can actually do a comparative treatment plan in our department. So for example, when I'm putting a SIMREC in, I can actually just duplicate it and say I would like to see a VMAT plan versus a CyberKnife plan versus a proton therapy plan. And essentially then we'll have 3 dosimetrists, 3 physicists, and at the end of the day, I'll have 3 plans to review. And so you can sit down and evaluate the 3 plans. This is a patient with a recurrent grade 2 meningioma after prior surgery, did not receive radiation therapy up front, and came to us for a particular technology. And essentially I could make 3 different radiation plans, sit with the patient, actually show them this and say, okay, plan number 1 has an increased dose to the brain. Plan number 3 actually goes through the optic nerves. I think plan number 2 is going to be best for you for these reasons. So we can actually make this decision by looking at the isodose distribution OAR doses for this particular patient. So why do I think about proton therapy for meningioma patients? I tried to summarize some of the features that go into our triage process for this patient population. First is age. I think that goes both ways. We have patients who are young with meningiomas that are working, and then we have patients who are quite elderly, potentially have other comorbidities. A patient actually just recently treated had a significant stroke 10 years ago on one side of the brain, and now they have a meningioma on the other side. And so you really want to potentially preserve brain, and that's why integral dose would matter for that particular patient. Functional status for the patient. Meningioma patients are typically more functional than they are for other primary brain tumor patients. Typically, these are located, as you can see here on the picture on the right, peripheral aspects of the brain. For those of you who treat with proton therapy, I'm sure just looking at each of those numbers, you can imagine a 2 or 3 field, quite straightforward or simple proton therapy plan that can be used to treat that lesion in that location. Typically, these are unilateral in presentation, unlike, for example, our high-grade gliomas that are crossing the corpus callosum or bilateral or multifocal. We don't have that typically with meningiomas, although obviously in the PET dotate area, we're identifying areas of multifocal disease. Also, the natural history and of the disease and prognosis. Even for those, for example, WHO grade 2 meningiomas, if you look at the intermediate risk cohort from R2G0539, you're still getting very high PFS rates at 3 and 5 years with upfront kind of maximal therapy. We also have to consider neurocognitive function in these patients, as radiation therapy is potentially the sole or a bimodality treatment after surgery in patients, and they're not getting hit with other things, for example, chemotherapy, that can affect their neurocognitive function. And so we have to think about the dosimetry of our radiation plans and the potential clinical impact that can have on the patient. And then finally, these patients have a risk of secondary malignancy, and there's always a concern theoretically of potentially secondary meningioma development in areas where they receive radiation therapy, given the known association between exposure to radiation and development of meningioma. So I just want to take a small segue here with our considerations of neurocognitive function in this patient population. So there's a number of factors that can affect a patient's neurocognitive function. They can be patient and disease related. I've listed a number of those here. We've talked about some of these so far, for example, age, the tumor type, potentially the grade of their disease, could be tumor size, the patients need anticonvulsants, anti-seizure medications, are they on corticosteroids, do they have an infection after surgery? There are treatment-related factors, how many surgeries has the patient had, do they have any postoperative complications? And then there's those that are radiation-related. There's the tumor location, potentially OAR dose, what's the total dose and fractionation that can be used for that patient? Typically, again, between grade 1 to grade 3 meningiomas, you're looking at a dose range that's only about 10 to 15 gray between the lowest dose you'd use and the highest dose potentially for like a recurrent grade 3. But the type of radiation therapy technique with regards to proton therapy decision or photon therapy, I think does matter for this patient population. Now, if you look at the dosimetric comparative studies that have been performed, and unfortunately, this is how every proton therapy talk essentially starts, there have been a number of studies that have demonstrated clear reductions to areas or substructures of the brain that are important for neurogenesis and neurocognitive function, specifically with proton therapy over any modern form of proton therapy. So this is one comparative series here showing a reduction in the mean, the maximum, the average dose to the hippocampus, amygdala, SVC, and the thalamus. Now, even with types of radiation therapy with regards to proton therapy, there are also key differences. So this is a second series comparing kind of modern IMRT versus passive scatter proton therapy versus IMPT. And so IMPT actually reduces the dose even further than what you see with passive scatter proton therapy. So as we look at the data for proton therapy, you have to clearly differentiate kind of which series have used passive scatter, some older techniques, versus which series are now using, for example, an MFO IMPT plan. And as I mentioned, for these patients, as we think about integral dose to the brain, obviously with IMPT, you're going to have a reduced dose to the remainder of the brain, as well as the brain outside the area that you're treating. For example, a supratentorial target, your infratentorial dose is essentially going to be 0. Now, as we transition from the dosimetric studies, which I think are less interesting, to what clinical impact that we've seen in patients treated in the clinic, This is a kind of summary table that I had put together for Neurong 2 years ago, looking at all of the series, as you can see here, prospective or very well done retrospective series. Most of these looked at low-grade or benign tumors, including patients with meningiomas. A select series looked at brain metastasis or high-grade glioma patients. And you can see that there are a number of neurocognitive measures that have been associated with dosimetric endpoints in this patient population and in patients who have brain metastasis. And as you can see here, these focus primarily on the unilateral temporal lobe being the dominant left side, bilateral temporal lobe, bilateral hippocampus, or even left-sided hippocampus. And I wanted to specifically pull out two series that I think are important for us as we use in the clinic. The first is actually a series of patients with nasopharyngeal carcinoma treated with the IMRT who are all followed with cognitive scoring tests. The reason why I like this series as a brain tumor radiation oncologist is that none of these patients underwent brain tumor surgery. None of these patients are getting the types of treatments that we think about for our brain tumor patients. And so this is essentially looking at the dosimetry and subsequent clinical outcome with regards to neurocognition. So you can think about that laundry list of factors that can impact neurocognitive function, and you can eliminate a lot of those for this patient population. And essentially in this series, the mean dose to the temporal lobes, as well as the high dose to the temporal lobes, were associated with deficits in short-term memory, language abilities, and list-generating fluency as three of the factors. Kind of the most cited NTCP model, though, for neurocognitive function for patients who have primary brain tumors came from the Wisconsin group, in which they looked at the dose-response relationship of the hippocampus dose and verbal memory. And if you see this NTCP curve, essentially if you want to keep the risk of having an impairment to be 15% or less, that cutoff was a D40 of less than 7.3 gray. This is actually important in the clinic itself. This is actually the very last plan that I signed before I went out of town yesterday. And this is a patient who has a atypical meningioma in the left temporal lobe. Actually interesting to Josh's last presentation, this patient actually has an area that showed up on their PET dotate scan as a focal area that was thought to be just postoperative changes. But you think about it, in a patient with a left temporal lobe tumor, you know, that entire area is going to get the full dose of radiation. So really, are you going to actually provide that patient any benefit with a different type of radiation technique? So for fun, I actually had the dosimetrist make a VMAT plan for this patient. And so you can see here that if you plot on the NTCP curve, if you look at the bilateral hippocampus dose for this patient, essentially their risk is about 90%. So they're pretty high on this curve. If you think about just the left hippocampus dose itself, it's completely gone. I mean, it's actually off the chart, but I couldn't extend the arrow any further. And so that's a potentially significant risk to that patient. This is actually the IMPT plan that I signed for that patient. It's a 3-field plan, one non-coplanar field. And you can see that D40 for just the left hippocampus alone actually was below that, say, 15% threshold. But specifically, that study was for bilateral hippocampi dose. And so if you look at that and plot that on that patient, it was actually 0.6 gray. So I'm showing you all of the isodose lines here, essentially going from prescription dose, which is in red, to 5 gray, which is in purple. So something that we don't even look at for IMRT plans, but as you transition to proton therapy, you start looking at those lower isodose lines. And that's where you can see a clear difference between the plans. Now, we actually do have evidence that radiation therapy technique matters. This is actually a phase 3 randomized trial for patients who had benign or low-grade brain tumors. They were randomized to stereotactic radiation therapy, which was what was called in this study. Essentially, for us in the United States, that's IMRT, versus conventional radiation therapy, which is essentially 3D conformal radiation therapy. So again, a randomized trial just looking at radiation therapy technique. And if you follow these patients out, you can see their full scale IQ is essentially 7 or 8 points higher if they receive stereotactic radiation therapy versus conventional radiation therapy. So this is a phase 3 randomized trial. This is level 1 evidence that radiation therapy technique actually matters. So I challenge, us as radiation oncologists to see, well, this is a 3D conformal plan for a patient with a different, actually a left-sided high-grade meningioma. This is conventional radiation therapy. And if I treated that patient with IMRT versus instead of 3D conformal, you can see the differences in the dose distribution. And here again, I'm turning on the lower isodose lines like 5 gray that we don't look at if you sign an IMRT plan. We have level 1 evidence that this second plan is better for the patient than the first plan. Do we really need level 1 evidence that this proton therapy plan, which is what I use to treat this patient with, is truly going to be better than this IMRT plan? Well, I'll review kind of some of the brief data that we do have. We're actually putting together a multi-institutional prospective proton registry for meningioma patients. This is actually the data as of an Astro presentation 3 years ago, maybe. About 150 patients we had collected so far. And you can see that the PFS for those patients who were initially diagnosed versus recurrent disease, which is actually a substantial portion of patients who receive proton therapy in the United States, this is about 8 large institutions, still has favorable results. Now, the issues that we have is that, as you can see on the second graph, is that you have WHO grade 1 meningiomas, essentially 100% control. And you can see for WHO grade 2 and for 3, but we have a substantial proportion of patients who have actually unknown grades. So I think further data is being collected to hopefully increase the median follow-up, clarify the WHO grades, especially as we have to think about what the modern grading systems are and have some uniformity in there, and then provide more radiographic and toxicity data before we can use this to actually demonstrate the true outcomes of proton therapy in this patient population, as well as actually identify the differences and comparisons between passive scatter and IMPT. This is a summary table that we had actually put together for a book chapter that is going to be coming out soon, looking at selected series of particle therapy for meningioma. And you can see the studies published essentially over the last 10 years. Mostly these are for WHO grade 1 and 2 tumors, and then for WHO grade 2 and 3 tumors. Those are treated to higher doses. There's some mixture of patients treated with carbon therapy as well. But essentially the 5-year local control as a summary estimate between all of the studies published so far is about 88 to 100%. But again, a significant proportion or weighting of that is for patients treated for WHO grade 1 tumors. There was also a systematic review and meta-analysis of all particle therapy outcomes that was put together in Journal of Neurosurgery. As you can see here, this is actually mostly the opposite, WHO grade 2 and 3 meningiomas. This includes patients treated with combined treatments of both proton therapy and photon therapy, or photon therapy and a carbon boost. Essentially, the doses are similar, but a little bit higher when you think about for the higher grade tumors. But the local control rates are overall reasonable, about 50% for those patients who have WHO grade 2 and 3 tumors, and about 85% for those patients who have WHO grade 1 tumors or higher. And then lastly, a tumor type which there's a significant debate about, which should receive proton therapy or photon therapy, is optic pathway meningioma. It's actually one of the last examples that Josh showed in his talk. But there has been a nice study that came out recently that demonstrated the efficacy and safety of proton therapy for this patient population. It's a nice retrospective series of 60 patients, all who had optic nerve sheath meningiomas, which is a pretty large subset for this particular tumor type. This patient population was treated to 5220 at 1.8 gray per fraction. There was a dose reduction to 1.7 gray per fraction for those patients who had had prior surgery or had baseline visual dysfunction, which is actually common. So about 87% had some reduction in visual acuity, but that was actually stabilized on long-term follow-up for all of these patients. So I think that's really key. This paper actually was done by ophthalmologists instead of radiation oncologists. And so those patients actually had very good visual testing and follow-up for that. And interesting to note that tumor size actually remained stable in all patients and then reduced in about 8 patients. But it is important to note that visual field, unlike visual acuity, did worsen in 8 patients. And there were 3 patients who did develop retinal hemorrhages after treatment. So there are some proposed evidence-based guidelines for how to use proton therapy for patients with intracranial meningiomas. This is actually proposed from the PSI group. And essentially here to summarize, for WHO grade 1 tumors, the reason to use proton therapy would be to decrease the probability of tumor induction. So we just talk about secondary malignancy, and the dose that they recommend is 50.4 to 54. But again, you can see the level of evidence is at 5. Again, for WHO grade 1 meningiomas, Proton therapy should be considered if clinically available, if you can decrease the probability of cognitive impairment. Again, the same dose level for those patients, but our level of evidence is actually 5. For those patients with WHO grade 2 to 3 upfront tumors, there's a consideration of dose escalation for tumor control. This should be considered if clinically available. The level of evidence for this is actually higher, 3B, because there have been a number of series, 3 of them are actually cited here, which have shown higher rates of tumor control and progression-free survival with dose escalation with proton therapy, something that we haven't really seen with photon therapy so much in the literature. So this is a consideration, at least. And then finally, for those patients who have recurrent tumors, proton therapy should be considered if they're non-elderly, initial benign histology, and if they've had previous irradiation at less than 60 gray. The retreatment dose has been suggested as less than 60 gray, given that there have been a number of series trying to salvage these patients with dose escalated particle therapy, and the toxicity has been pretty significant. It's over 30% of patients have a high grade toxicity if you exceed 60 gray in the retreatment scenario. So that's been brought down to 60 gray as a max. There are several ongoing particle therapy studies, though, that will prospectively evaluate the role of particle therapies, including proton therapy. Mostly these are used, though, as a boost or as a sole modality in combination with other treatments for the higher grade meningiomas. I've listed 5 of the studies here. There's carbon ion therapy for those patients with atypical meningiomas, comparison of protons versus carbon for skull-based meningiomas, dose escalated proton therapy for higher grade meningiomas, and then a study looking at immune checkpoint inhibitor therapy and hypofractionated proton therapy for recurrent meningiomas, and then again, proton dose escalation for those atypical or anaplastic meningiomas. So in conclusion, I think proton therapy is considered at least for patients with progressive or recurrent grade 1 meningiomas, upfront or recurrent grade 2 meningiomas. At least at our facility, we're treating them at least upfront or recurrent grade 3 meningiomas. But I think you should consider all the radiotherapy tools in your toolbox. For example, there are some patients who would be better served, for example, with radiosurgery or stereotactic radiation therapy if they have a small progressive tumor. You should consider patients who have a potential dosimetric benefit to photon therapy over photon therapy if you do a substructure analysis of comparative treatment plans. So we do this for a majority of our patients, and that kind of leads to that decision making for proton therapy for that particular patient. And we have a triage process for that. And that will actually go into probably how we design the PTCOG guidelines later this year for this patient population. There's retrospective single and multi-institutional data sets that do support the role of proton therapy with regards to safety and efficacy. But again, so far in the literature, I think as of last year, there are about 500 patients treated with proton therapy for grade 1 meningiomas, and about 97 patients who have been published on for grade 2 and grade 3 meningiomas. So it's still small overall. Proton therapy guidelines for CNS malignancies are forthcoming, and that will include proton therapy or be specific to that. And then there are numerous trials which are currently evaluating the safety of proton therapy or even efficacy with dose escalation that will potentially provide prospective evidence and then lead to better patient selection for this technique. So I want to thank the organizers for having me here today.
Rupesh, thank you so much. That was just an absolutely amazing talk. Like I said, I knew it was gonna that was gonna be a perfect segue from Josh's talk with regard to radiation treatment planning to actual treatment. I think there's going to be huge opportunity in the future for marrying this advanced imaging with more targeted approaches to radiotherapy and thoughtful design of radiation treatment fields based upon that advanced imaging. So I have about 1 million questions in my mind, but we'll hold those until, because I'm going to be very excited to hear the discussion of this with our surgeons and then obviously the radiation oncologists that have given this talk as well. But we'll hold those until the end. So we'll move on to our next talk. But thank you so much. I think that was just amazing.
Yes, I agree. That was a great talk. And, it's great to see how we're expanding our toolbox with more focus to patients' quality of life and their cognitive function, which is really important for a disease where patients do live a long time, and it's important for them to maintain a good quality of life. And as we saw throughout the day, that it is a multidisciplinary approach. So with that, it's my great pleasure to introduce Dr. Manish Aghi. Dr. Aghi is a professor of neurological surgery at UCSF Will Institute of Neurosciences. He's an internationally recognized accomplished physician scientist, and his research work is funded by NIH. His clinical practice focuses on surgical management of brain and skull-based tumors, with special emphasis on pituitary surgery, complex skull-based surgical approaches, and minimally invasive endoscopic skull-based surgery. And today he will discuss complex surgical approaches for management of meningioma. And I'm really looking forward to this talk, Dr. Aghi.
Hi, 1 second. I'm just going to share my screen. Thank you for having me. I really appreciate it. Having some technical difficulty with screen share. Let me see.
The button is at the very bottom. Is it grayed out?
Yeah, it's saying I have to allow it, but I have allowed it.
You may have to log back out. I think we had this issue.
Unfortunately, it looks like I have to. Give me 1 second.
Okay.
Should I log out?
Yeah, you have to log back out. Log out and then log back in.
Okay. All right, 1 second.
So while Dr. Aghi is getting himself logged back in, and before this talk, I just want to remind the attendees to please utilize the Q&A form at the bottom. We'll have a great panel discussion with our panelists that have already talked this morning, Dr. Swagerman, Dr. Palmer, Dr. Kotecha, and obviously our upcoming talk with Dr. Aghi. So please feel free to put those questions in there. They'll stay on, and we can make sure those get answered for you at the end of the talk.
All right, I think I have it. 1 second. Here we go. Can everyone see that?
Yes.
All right. Well, thank you for having me. Sorry for the delay there. I'm going to be speaking about surgical approaches for anterior skull-based meningiomas. And just a quick disclosure, but not relevant to the talk. And so I've broken this down into a few parts. I think for surgery, meningioma location is so crucial to how we think about approaches. So I'll touch a little bit about the impact of meningioma location on biology and approach selection, although much of that content will be in the second panel where they touch on the biology and the molecular biology of these tumors. And then go into detail on anterior skull-based meningiomas as an overview, and then talk about two specific locations that are common in my practice, olfactory groove and tuberculum sella. So in terms of meningioma location, and we've seen this is really a heterogeneous disease, and this not just molecularly, but in terms of anatomic locations, and that obviously goes without saying. Goes a long way towards determining your surgical approach. We like to think of dividing these approaches into anterior and posterior approaches, based primarily on the divisions around the sphenoid bone, and then medial and lateral approaches based on the anatomy as relates to the carotid artery in terms of how you approach them. But location, as the work from many groups, including Gelleray and some of the panelists in the second half of the day this morning, have shown location influences biology, and so mutations correlate with anatomic location, as you can see here. And I won't go too far into that, but it is relevant in the sense that it becomes extremely detailed with mutation influence being impacted by tumor location. And the reason that's relevant is that the mutations will influence biology. And so certain types of meningiomas are more likely to have peritumoral brain edema, and other types are more likely to be more proliferative. And so these days, it's very common for us to have genetic testing for all these tumors, and it allows us to have conversations with patients, even when a tumor is grade 1 and completely resected, about the nature of their tumor and the relative recurrence risks and what the future may hold should it recur. But that's obviously the subject of more detailed discussions later this afternoon. So without further ado, I've chosen to focus on anterior skull-based meningiomas, which, as I mentioned, are the focus of my practice. And the anterior skull-based meningiomas represent just under 9% of all meningiomas, and they're going to be divided based on their origin from anterior to posterior as olfactory groove, planum sphenoidale, and tuberculum sella. The chiasmatic groove separates the planum from the tuberculum, and as a result, the tuberculum sella meningioma patients invariably will typically experience vision loss as a part of their clinical presentation, but as you go more forward, that symptom is less common. And then the olfactory groove is defined as originating from the cribriform plate, whereas the planum and the tuberculum arise from the sphenoid bone. And as a result, the olfactory groove and the planum are in the anterior cranial fossa, while the tuberculum is situated in the middle cranial fossa. And these anatomic landmarks are relevant as we think about these tumors, not just in terms of surgical approaches, but clinical presentation as well. Because the olfactory groove meningiomas are bounded primarily superiorly and laterally by the frontal lobes, they can get quite large at presentation, which plays a role in determining how we think about surgeries for those tumors in a very distinct way compared to the planum or the tuberculum tumors, which are smaller because once they reach a certain size, the patient will achieve visual symptoms and present earlier in the disease, particularly in the tuberculum. This proximity to the frontal lobe means that the olfactory groove meningiomas may present with an impairment in KPS, which is relevant as we think about the surgical approaches and the need to reduce frontal lobe edema as part of the decision-making surgically. And not surprisingly, those patients will experience an improvement in KPS when they undergo surgery. The olfactory groove meningiomas uniquely present with anosmia or hyposmia. And even when patients are clinically unaware of it, formal olfactory testing in the clinic will invariably reveal some degree of olfactory impairment in olfactory groove meningioma patients. Visual symptoms, as I mentioned, become increasingly common as you traverse from anterior to posterior. The extremely anterior tumors in the olfactory groove, if they are going to cause vision loss, which does happen in about 1 out of 4 cases, will have to be quite large to do that, whereas the tuberculum sella meningiomas, even at 1 to 2 centimeters, have a majority of their patients experiencing visual loss. Again, it's very important to get preoperative involvement of your ophthalmologist, even in patients who deny visual symptoms, to formally document their full preoperative visual exam so that you know postoperatively what the changes have occurred, whether they be for the better or in some cases for the worse. And then lastly, there's a variety of symptoms such as vertigo, seizures, hemiparesis, and psychomotor decline that are unique to the olfactory groove meningiomas, which as they get larger can impact the frontal lobe and the white matter tracts. And this is also important to formally document before you take patients to surgery. In terms of surgical approaches, broadly speaking, we talk about these as lateral versus median approaches. For tumors that grow superiorly, you can come from above via an intrahemispheric approach. Tumors that extend more anteriorly, a subfrontal approach can be extremely useful. And then arterional is for many people a workhorse. And I would say that one of the themes I'd like to emphasize here is that there isn't really, in my opinion, dogma. It's more a function of your comfort level and experience with these approaches, but I will talk about some principles that have proven to be true across multiple studies and experiences, not just my own. These approaches can also be thought of anatomically in the lab in terms of what the bony removal and involvement is, as well as the complication profile unique to each approach. But you can remove bone laterally with a terional or frontally with a bifrontal or subfrontal, unilateral or bilateral approaches. And then supraorbital approaches have the least amount of bone removal to get access to the anterior skull base. And then the complication profile is unique in the sense that more midline approaches have a slightly higher rate of infection, whereas more lateral approaches have a slightly higher rate of post-operative epidural or subdural hematomas, not surprisingly, as the lateral aspects of the brain relax during the procedure, creating some space where those complications can arise. And so it's very important when counseling patients about different approach selection to go over those risks uniquely. And no matter what approach you ultimately advocate, the approaches are part of the discussion with the patient. So I present, starting with observation and then moving to radiation as a treatment option, as the previous patient speakers mentioned. And then finally, when I get to surgery, I mention all of the approaches and the pros and cons of each before focusing in on what I might be recommending for that specific patient. So I wanted to touch on, in my remaining time, in a little more detail, two specific locations and how we think about surgery. So the first is the olfactory groove at the anterior end of the anterior skull base, and then I will conclude by talking in some detail about the tuberculum sella at the posterior end of the anterior skull base. The planum, obviously, as a location, represents a hybrid of these two approaches, and so I haven't included that content separately because often it sort of spills over and borrows on some of what I'll talk about for each of these locations. So starting with the olfactory groove, these are about 3% of all meningiomas, and as I mentioned, they grow to a considerable size. Mean diameter at presentation is a little over 5 centimeters, and this is due to the unawareness of anosmia as an early symptom. Invariably, the patients who are fortunate to catch these meningiomas at smaller size will be those who rely uniquely on olfaction. And so there'll be people who are like a chef or in some line of work where they will be very sensitive to smaller tumors. But for most of us, unfortunately, these will present when these are larger. If the patient is formally tested and has normosmia, which, as I mentioned, is rare at the time of presentation, and if the tumor is biased to one side, then you have a chance of preserving olfaction, but by no means is it a guarantee, and patients should be counseled that it is highly likely to be lost. But with smaller tumors biased to one side, there is a chance of preservation when a non-endoscopic approach is chosen. But preservation of function ipsilateral to the tumor in a unilateral tumor is difficult regardless of approach. And it should be mentioned that these tumors have a variable recurrence rate in the literature. But in some series, it does get higher than typical for meningioma, and that's primarily due to the larger size. So even when you think you are achieving a cauterization of the dural attachments or through an endoscopic approach or resection of the dural attachments, these are typically large tumors that are going to have a wider base than you anticipate, which creates a risk of recurrence from the skull base, even in the setting of what might appear to be a radiographic gross total resection. And so these tumors do need to be watched closely in the postoperative period. So in terms of surgical approaches for the olfactory groove, I'm a little biased and still feel like the oldies are the goodies, and so the old sort of historical workhorse remains very effective for this disease is the bifrontal craniotomy, which is really a subfrontal approach with or without orbital osteotomies. I find that draining CSF via lumbar drain can assist in brain relaxation, which is important when you want to get good access to the tumor without retraction. And typically you don't need retraction because the tumor will show itself quite early if you position the patient with the head angled down and maybe have a lumbar drain, as I mentioned, to relax the brain, then the brain will fall away. And then although we like to think of the endoscopic approach, which I'll get to in a moment, as addressing the blood supply to the tumor early on. The reality is, with an olfactory groove meningioma, you can address the anterior and posterior ethmoidal artery blood supply early on, sometimes even extradurally before you open the dura, to provide good exposure to the tumor without having to deal with early bleeder. And so taking down that blood supply early on, either extradurally or even intradurally, is extremely important for these cases. And so this approach had been over time moved away from, but I should mention I still routinely use it. These are big tumors, and a big approach can provide very good access. And as you get experience, the cosmetic results with this approach, incisions behind the hairline, and you know, my colleague Dr. McDermott has a lot of good photos of patients postoperatively with very satisfactory cosmetic outcomes. And I think it is an approach that should be not underemphasized despite the advances. Some of these advances include the eyebrow supraorbital craniotomy, which has really reduced operative time, about 15 minutes from skin to tumor. Good access to the contralateral side. When I first started, I was skeptical, but sure enough, the lateral access, as I'll show you in a moment, is really quite good. The limitation is more getting posteriorly, and so this is really best used when the tumor has its AP diameter, more than half of it, in front of a vertical extension to the anterior wall of the sphenoid sinus. And this just relates to the instrumentation and the ability to get deep through the working corridor that you get through that bone flap behind the eyebrow. But the cosmetic results are indeed outstanding, and the complication profile is low, and the access to the tumor is very good. So this approach has come into favor for a number of these cases in recent years. The endoscopic endonasal approach for the olfactory groove, although you know, it's certainly appealing as the endoscope has gained ability to gain access to the entire anterior skull base, I would say, as a matter of personal opinion, which is certainly what I'm here to provide, but not necessarily dogma, is that there are some limitations here. And so big tumors, calcified tumors, tumors without a cortical vascular cuff can limit the ability to achieve a gross total resection through this approach. And there's a higher CSF leak rate here than compared to other endoscopic, than compared to the endoscopic approach for other anterior skull base locations, because of the challenges achieving closure. It can be done, and I'm not covering closure today in the interest of time, but happy to answer some questions about it. And we've certainly been able to do it, but it is more challenging. Anosmia is virtually guaranteed. And obviously, if the patient has some preserved smell prior to surgery, that's an important consideration. Use of angled endoscopes is crucial. So the 30 or even 45-degree scopes can be crucial to provide that view, because you really need to be able to see to the back wall of the frontal sinus if you're coming in from below. And this is work that Ted Schwartz from Cornell has done to illuminate what you're gaining access to when you compare the eyebrow to the endoscopic endonasal. And you can see that the endoscopic endonasal gives that nice posterior axis along the anterior skull base. They both can give access to this superior posterior corridor, and then the eyebrow gives access to the anterior aspects riding high. But I should mention that the bifrontal, extended bifrontal, gives you access to all of that. And so I think as we think about these approaches, it's very important to balance the need and the desire that we all have to be minimally invasive with the need to access these tumors, which are indeed quite large. A number of people, I don't have a slide on it, but have advocated for staged approaches. So combining an eyebrow with an endoscopic endonasal. But to me, it's, if you're talking about doing two procedures for one tumor, then you may as well go to the bigger sort of bifrontal and just get it through one approach. But again, that's a matter of opinion. It's not evidence-based. It's not based on randomized trials, but it is some of the thoughts I have on these tumors. And so in my remaining time, I want to touch on tuberculum cello meningiomas, which, as I mentioned, present in a smaller size with vision loss. And here you get to something where there really is sort of active debate and a need to think about how do we best define approach selection. This remains an ongoing challenge in the field. And what we're considering here is sort of, there's obviously a number of approaches, but terional, certainly with or without the orbitozygomatic component, provides good access to the tumor inside the particularly when there's vascular encasement or canal involvement. If you come in on the side of primary canal involvement, you get a very nice decompression and access to the tumor through that approach. And this is to be contrasted with the endoscopic endonasal approach. And I wanted to talk a little bit about the anatomy here, which is very important. It's always important, but particularly important when you're doing endoscopic endonasal surgery for tuberculum cella meningiomas. And so as we see the anatomy through the transsphenoidal corridor, you have the carotid and optic protuberances, which are separated by the medial and lateral OCRs. The medial OCR is really the ventral surface of the medial anterior clinoid, which is seen from above as an important landmark. And the lateral OCR is actually just molded by the pneumatization of that optic strut of the anterior clinoid. And so when you're working and you've drilled out the bone over the pituitary gland, you've drilled out the bone over the tuberculum cella and the plenum sphenoidale, all seen from below through the nose. The next step is then to remove the bone over the superior inner cavernous sinus, which gives you access to the suprasellar cistern, the CSF space that houses the pituitary stalk and will house the tuberculum cella meningioma. And then when you remove the bone that is over the medial OCR, that gives you access to the carotid canal, the optic canal, and the medial cavernous sinus. And it's analogous to the keyhole during a terional craniotomy. And its removal of that bone actually gives you access to the optic canal. And so even though we appropriately think of the terional as the best way to get access when the tuberculum cella meningioma invades along the optic canal, the ability to comprehensively remove the medial OCR does give you access to some tumors invading the canal, and I will show some examples of that. We and the team at Cornell have talked about the approach selection and the impact of approach on your chances of achieving a gross total resection when you compare the terional or the orbitozygomatic to the endoscopic endonasal approach. So Stephen McGill and Mike McDermott at our team a few years ago created a tumor grading scale that offers insight into whether surgeons in the series chose a transcranial or endonasal approach. And this was based on tumor size, 1.7 centimeters being the cutoff, canal invasion scores, whether it's unilateral or bilateral canal invasion, and 3 millimeters being the cutoff, and then the arterial involvement score, which uses 180-degree encasement as a threshold, but abutment is 0 points on that scale. And then the team at Cornell offered insights into whether the endonasal approach can achieve a gross total resection, again, basing their scoring system on unilateral or bilateral canal invasion, and then incorporating some of the aspects of our canal invasion, carotid encasement, and then extension relative to the optic nerve. And so I want to conclude in my remaining minutes by just showing some examples of cases. And the take-home message from these cases, which are going to be cases that were operated on endonasally, is that one variable that these scores unfortunately can't account for is tumor consistency. This is a challenge throughout the field, is that we have a very difficult time radiographically predicting tumor consistency. And so this is an example of a tumor that had some canal involvement, a 59-year-old female with some left temporal vision loss, and a 2.4 by 3 by 2.8 centimeter meningioma with some left canal invasion just below the 3 millimeter cutoff, and abutment of arteries, but not encasement. And the mass, I don't have the T2, but was mildly hyperintense on T2. And scored as a 211 on the UCSF scale, which suggested that would rarely be done endonasally, but on the Weill Cornell score suggested a 95% chance of an endonasal GTR. And this proved to be quite soft and advantageous. So after drilling out the bone and cauterizing and opening the dura and getting into the tumor, we as is often the case, learned early on that we had a very favorable tumor with almost a liquid consistency, and we're able to deflect it off the arachnoid. And normally I like to preserve these tumors, but we did our best here, but it's just falling apart as we're peeling it off the arachnoid. And this was really quite favorable for this approach. And so the point being that despite our best attempts to use our experience and our scoring systems to predict the best approach, sometimes until you get in, you just don't know for sure what's going to produce the best result. And here, this was really quite favorable. We were able to roll it off the arachnoid attachments, revealing the arterial anatomy, where, as I said, we just had abutment but not an encasement. And then I turned the attention to the inferior tumor, and so identify and preserve the pituitary stalk. And the risk of DI through this approach is really quite low and comparable to what we see transcranially. We watch these patients closely for DI, but the rate in our hands is about 3 to 4%, and typically of a transient nature. And then lastly, as I mentioned, there was a few millimeters of canal involvement, but we were able to, with the angled scopes, and I will forward this a little bit. With the angle scopes, we were able to remove the left lateral tumor by getting the 30-degree scopes in there and drilling out that bone and delivering that last bit of tumor out of the canal, and then peeking at the nerve with the angle scopes and following it out along the canal and seeing it to be free of tumor. And so that's the first example I wanted to present. I want to be cognizant of the time. The second example is a tumor that was smaller with vision loss. Again, no canal involvement, no vascular involvement, and not anticipating it to be as firm, and a bit equivocal on the UCSF score in terms of endonasal versus transcranial approach. It's favorable by the Cornell score. In this tumor, what really the take-home point is just having all your instruments available. And so for this, once we got into the tumor, forward again, this proved to be a more firm tumor, fibrous tumor. And so we used an ultrasonic aspirator here to debulk the tumor internally, nowhere near as soft as that first tumor. But it proved to be amenable to the ultrasonic aspirator. And once it was internally debulked, eventually, and the point being that we have all the tools available and choose the tools once we get into the tumor. And eventually, we were able to take down some of it sharply, continue to debulk it until finally it was small enough to be able to deliver itself out in one final piece, leaving behind the optic and the arteries to be inspected at the conclusion of the case. And then the last one I will present, just to sort of reiterate this theme of things are never what they seem, is what looked like a calcified tuberculum cellular mass in a patient with vision loss, which we were prepared to incorporate into the drilling through the endonasal approach. But in this case, the calcifications proved to be microcalcifications, and the tumor itself, once we opened the dura, proved to be basically like pearls that delivered themselves out without really much difficulty at all through just some soft aspiration. And those pearls, as you can see there, came out without needing any sort of tool beyond just suction and dissection. And despite being extremely hyperintense on the CT, this tumor, which is from earlier this year, eventually delivered itself. And there you can see those pearls that I mentioned earlier, which we were able to peel off the arachnoid attachments, leaving us eventually with a full optic decompression. And this was an interesting case that proved to be a simomatous meningioma that was resected without needing anything fancy, despite appearing to be quite calcified on the preoperative imaging. And so I didn't necessarily create a conclusion slide, but really just wanted to say that the anterior skull-based meningiomas, there's a number of approaches. I think surgical familiarity is an important part of the approach selection, and understanding the anatomy and the limitations of each approach, being prepared to adapt and switch approaches if needed, and not being afraid of being maximally invasive when a tumor is big. At the end of the day, patients are going to be satisfied just as much by your extent of resection than by the whether or not they have an incision. And so I think it's very important to be flexible and accommodating in order to achieve the best results. And so with that, in the interest of staying on time, I will conclude, but open to any questions as we transition into the panel.
That was a great talk, Dr. Agi. It was a great description of the surgical procedures. And I think you hit the most important point, that we should know all the approaches and do what's the right approach for the patient when it comes to the right tumor. You know, for some surgical approaches like vestibular schwannomas, people are combining, say, open and endoscopic for the same procedure. Do you ever use that for this location? And if so, when?
So endoscopic assistance for keyhole or supraorbital is actually really helpful. And so that's an example of, one approach where you're using endoscope assistance. There are people who've advocated for truly, as I've alluded to, staged approaches where you maybe debulk a large olfactory groove meningioma, get it small enough, and then roll it out from below. The team at Ohio State has talked about that, and others have. I have not personally been using that in my practice. And then I know folks at Cornell have talked about actually, combining keyholes with endoscopic as two separate things. Beyond endoscopic assistance in one approach, that's been the limit of my combination of the approaches.
And Dr. Swagerman, do you have any additional comments on that?
Sure. I think great talk, Dr. Agi. Appreciate all your comments, and I think you talked a lot about what we talk about here is you're balancing trying to get the whole tumor out versus patient satisfaction, what they're trying to achieve, and so I think that's an important part of this. In our hands here, again, I prefer a single stage approach. I think that patients do better when they know that you get things taken care of in one approach, and so that means that sometimes you are taking a bigger approach to get the whole thing out. I think that there's benefits and drawbacks. I think it kind of depends on where the patients are and what they expect. I think that the Ohio State group, as he said, really has done yeoman's work talking about their combined endonasal and transorbital or eyebrow approaches. But I think it just depends. I think that you take each case individually and determine how to approach it based on the patient and the tumor itself.
I think those are all fantastic points. Why don't we have our other speakers for this early morning session rejoin us, Dr. Palmer and Dr. Kotecha. I think through all of these talks, we've clearly identified that this is obviously a multidisciplinary approach, and I'm going to ask you guys to kind of turn a mind's eye towards the future. I think Josh clearly touched on that with regard to advancements in more modern imaging approaches. I'm curious from the surgeon's perspective, how you guys foresee Dotate having an impact, Dotate PET scans having an impact on you guys' approach, especially if we're seeing that there are, these skip lesions that Dr. Palmer had shown, or areas that were not necessarily easily visualized on standard MRI scanning. What are your surgical thoughts with regard to advanced imaging and the approaches that you take to these tumors?
So I certainly incorporate it when I'm seeing patients who've had prior surgeries, particularly for atypical meningiomas, and just comprehensively evaluating for intracranial or even extracranial sites of disease that may not have been anticipated based on standard MR imaging. I have not necessarily used it up front for newly diagnosed patients, but I'd be curious as to others' experiences.
Yeah, I think that Dotate scan is changing the way we look at what we talk about gross total resection. I think that, historically surgeons have either said they took the whole thing out or didn't. And I think this is a better way to evaluate that. And that allows us, again, to have a better idea what has to happen next. As we talked about many times before in this course, I think this is a collaborative work between the surgeons, radiation oncologists, and neuro-oncologists to determine how best to take care of people. And as said many times before, I never use the word cure because I can't guarantee that. And I think Dotate's going to expand that further and show that we don't necessarily cure these people with surgery. There's a lot of different things that happen that we don't necessarily expect. And I think that allows us to take better care of people, and more importantly, try to predict the future a little bit better as to what to expect from if we have a positive Dotate scan on a post-op patient, knowing that they may have recurrence, and we have to keep an eye on that, along with things like following up on genetics and future treatment options from a chemotherapy standpoint. I think that there's a lot of things coming down the pipeline. I think it'll be really interesting and have real benefits to our patients.
And I think what really caught my attention is the study that you showed where it looked like post-operative changes, but it did uptake Dotate, so it is. And, especially skull-based, when we do the resection, a lot of things enhance post-operatively, and we just call it post-operative changes. But to have that additional imaging to delineate that, I think will impact patients' overall survival, because that will dictate if we should do adjuvant treatment such as radiation or not. Because I feel like for a disease where the natural history is still unclear, like a grade 2, if we should radiate, shouldn't radiate, it's still kind of a open-end discussion. And these advanced imaging technology, I think, will help us answer those more in an evidence-based manner.
So to that, actually, maybe I'll ask Josh a question, if he doesn't mind. If you have a patient, since you have the PET Dotate program up and running, and you have Bn003 open, if you have a patient who has a gross totally resected WHO grade 2 meningioma, and you do your 6 to 8 week delayed scan, and you see something there, would you have equipoise in that patient going onto that trial and being randomized? Or do you think we don't have enough data that should change our decision?
I personally, that's a great question, because it's actually happened a couple of times to me that I personally don't think we have enough good data to support that the PET scan is like a gold standard and we should always use it to dictate treatment changes. And so although I'm getting it, that's why I wanted to highlight a couple of the really kind of key cases where, we probably would have pushed for radiation. We didn't do it. The PET was negative, and it turns out it's many years later, never came back. Or like a patient where, was that patient particularly really didn't want radiation. We tried to get them onto the study, got the PET, showed avidity. We're like, are you sure you really want to wait? They chose to wait, and it recurred. And so I think that integrating it into prospective studies to validate that it can actually help with treatment decisions is going to be critical. At the moment, I don't use it solely for that purpose. I do for everybody, and this is probably may just be me, but whenever I'm getting the Dotate, I end up changing what I'm doing if we're getting it, but I don't change whether or not we treat the patient or not, or kind of the overall strategy of like imaging, like timing. And so we sort of keep it standardly like we would on the Bn003 study. But I think I worry that it's like a lost opportunity that Rome and Bn003 both probably won't have very many or any PET images. And so it's almost like we'll have to redo the study now in the PET era. But yeah, it'll be interesting.
I think that's a concern. Just from a practical perspective, guys, and Rupesh, you had commented on this in your talk. Regionally and nationally, there's variation in terms of groups' abilities to actually get a Dotate PET approved. And obviously, living in an era of peer review, which we all cringe about. Can you just provide some practical points for the other providers on the call with regard to how you go about getting those scans approved for utilization and for clinical decisions?
Yeah, I'd be interested to hear others that are doing it. When I started doing it years ago, it was very difficult. Like I think we started doing this in 2018 to 2019, and every single patient had a peer-to-peer, and the peer-to-peer was always very against it, because really all we had was the neuro-oncology consensus statement saying that there's a lot of good evidence in the European data that shows the utility. I think since then, groups all over the US have been able to publish, and so we have a lot more data now. And I've had a lot less peer-to-peers, like a lot of these get approved now without me even having to discuss with them, which is nice. At least the way that we do it is we include on the diagnosis code that they are neuroendocrine cancers of the cerebral meninges and meningioma all together on the request, given the fact that they are SSTR2 positive tumors. That typically has allowed us to get these through, especially for higher grade tumors, especially for like a malignant, when we put malignant neuroendocrine of the cerebral meninges. The challenge is when the peer-to-peers for some insurances, even in Ohio, do still request us to put through like an appeals letter. And so we have a few appeals letters that have worked for us in the past where we just essentially summarize like the studies that I showed, that there's a huge improvement in control as well as survival in patients that are getting the PET scans.
So for us in Florida, about 2019, we didn't get any of them actually. And then in 2020, I think we probably got one patient. 2021, we started getting a trickle of them at the end of the year, maybe one or two or three. Right now, I'm actually batting more than 50%. So it actually has changed so far for the last couple of months. So we're actually, as I mentioned, we changed our entire workflow. We're getting it for every patient. We're at least ordering it for every patient. But about half of them are going to peer-to-peer, and they will ultimately get rejected because essentially at the peer-to-peer review stage, they'll say MRI is actually the gold standard for defining the extent of the disease. And even for radiation planning, it shouldn't change. And despite whatever evidence we show them about skip lesions, despite our own personal, experience as well, it still is quite a challenge. Actually, I messaged Josh on the chat that I have a peer-to-peer at 7 a.m. on Monday morning for a meningioma patient for a PET Dotate scan for a recurrent tumor. And we've tried to discuss this, in some peer-to-peers even have just been motivated with just talking about the experience. Some want to go through the data. So it's been kind of a mix all over the place, but it'd be nice to have some uniformity at least.
And quick follow-up, those are always happening in the post-operative setting, not pre-operative setting, or both?
So for us, we're getting it at the time of radiation treatment planning. So for example, I have an optic pathway meningioma that I actually just looked at the scan for this morning. So for a patient who just got SIMmed yesterday. So anybody that is getting planned for radiation, we're automatically just ordering it, whether they're post-op, whether they're intact, because actually for some of those, I'm planning for a grade 1 meningioma patient. And actually when I got the PET Dotate scan, even to plan for radiosurgery, it picked up 3 other lesions in the contralateral part of the brain that actually have been missed on MRI. And this patient's been followed for 3 years and finally had growth of their single lesion. So, it will help us to determine to follow those patients going forward.
And we currently also don't do them for surgical planning, like our team with Danny Prevedello in the group. They haven't started utilizing them for that purpose, but I think we've run them over as a surgical group, how useful this is for them when they work with us to do radiosurgeries. And to highlight the sort of cases that Rupesh was saying, we had a couple of patients where there was no known multifocal meningioma disease that we did pick up, and it was actually a familial meningioma disorder that we ended up diagnosing, and we found that her mother had a meningioma that was undiagnosed and ended up publishing that case. And so it's been extremely useful because we were able to find, unknown genetic disorders in patients. We're finding early stage other neuroendocrine cancers in these patients that they wouldn't have found. And so I think it's really interesting as we're getting a larger experience, and I'd be interested to see, because like the largest experience really is Stephanie Combs in Germany. He's got hundreds of these, hundreds and hundreds. And so I'd be interested to see her experience with sort of the incidental findings and a lot of the multifocality of disease that historically we probably just didn't understand and would find 10 years later, you know.
So Dr. McDermott at our institution now we're trying to get it as part of our planning process. So we've kind of built it into our radiation workflow. I will tell you they're probably having a more difficult time because the lack of data that it would change surgical planning. And so we're having better luck essentially getting it for radiation planning than they are for surgical planning, given the lack of data. But they are at least trying so they can build that data set.
And does the uptake changes between grade 1 to higher grade? Is it the intensity different, or is the uptake pretty similar across all grades?
That's a good question. I think there's good evidence that the uptake is higher for higher grades. And so I showed one case where a patient it was a solitary fibrous tumor, but the aggressiveness in Ki-67 increase actually increased the intensity. That's also been showed for grade 1 versus grade 2 versus grade 3 meningiomas. I think Jana at Cornell has some good evidence there. And so it should have an impact on the aggressiveness of disease.
So is it something that could be used to predict the grade before even surgery, before even getting to pathology, based on the intensity that we're seeing that could change surgical planning when we're thinking about, what grade? We always want to do gross total resection, but, many locations, things become more complicated. And if we kind of had an idea what grade this might be, that might change surgical planning.
That's actually a really good point. I think that would be, unfortunately, the data that supports the grade versus uptake isn't so good that we can actually use it as a predictive model. Like we can't say this SUV for this particular patient will be a grade 2. It's more like descriptive studies, retrospective ones, where we see that there's an increasing trend of SUV uptake can be predictive for higher, but there's no set cutoffs. And the other challenge is, depending on like the way that they attain the PET scan at different institutions can also play a role in like the SUV uptake. And so the standardizing across institutions would be somewhat difficult. But I think in part, that is something that I know Jana at Cornell is looking at, is trying to get a large enough data set pooled with a lot of different places to try to understand that question. And I agree with you, that would actually be a really important tool from a surgical perspective if we had enough data to be able to look at that. But I think that's probably, unfortunately, years away.
Well, this was just fantastic, you guys. Thank you so much for your time this morning. We have a planned break at this point in time. So grab some coffee and please rejoin us. We will plan to reconvene at 10:30, and please come back. We have an equally exciting second half of our morning, and would be good to see everybody back and participating in discussion and questions. So thank you guys very much.
Thank you.
Thank you.
Thanks, Joe.
I think we're at 10:30, so I
Yep.
think we should get started without any further delay. We had a great morning, and our rest of the day looks equally good. I would like to welcome everyone back for the late morning session. And it is my honor to really welcome an internationally recognized physician scientist, Dr. Gallium Zeta. Dr. Zeta is a professor at at the Department of Surgery, University of Toronto, and is the chair of neurosurgery at Toronto Western Hospital. She leads surgical oncology and is a senior scientist at Princess Margaret Cancer Center and Cancer Research Institute. She also holds a Wilkins Family Chair in brain tumor research, focusing on building surgical clinical trials for brain tumor patients. She's also the past president of Society of Neuro-Oncology. Her clinical practice focuses on surgical neuro-oncology, and she seamlessly integrates her basic science research and her clinical practice. And today she's going to discuss her translational research work in meningioma. And it's really our pleasure to welcome you to this symposium.
Thank you, Dr. Dey. It's nice to put a face to your name. Both my daughter's middle names are Dey, because in Persian that means that's the month that they were born. So.
Oh, is that, which month is that?
It falls between half of December and January, roughly.
Okay. Awesome.
Okay, so thank you very much for the invitation. I was logged in and listened to the morning presentations. I really enjoyed it. Very nice, thorough discussion. I have no conflicts or disclosures. I did want to acknowledge all of the people who really support me in the work that I do up front. I'm the chair of neurosurgery at University of Toronto. We have an amazing team of neurosurgeons that I have the fortune of working with. And I have a very unique lab, mix of variety of backgrounds, talents and expertise. And I think really all of the work is done by them. And then of course my family, who put up with my erratic schedule, and they keep me balanced and sane. So I wanted to speak to the theme of the meeting today, of course, about meningiomas, and this tumor is not unknown to you. They can occur anywhere in the cranial and spinal axis. Majority of them are resectable, as surgeons were able to achieve a gross total resection, find the planes surgically under microscopic techniques, and be able to resect them fully. However, there are tumors that on presentation have significant involvement to the neurovascular structure, where for preservation of function, we may be pushed to leave residual tumor behind, and some of them have pathology that is concerning. If you look at the CB Trust annual report for incidence of meningiomas, you in fact see that a significant portion, more than any other, is meningiomas for brain tumors. If you remove what is traditionally thought of as malignant brain tumors, meningiomas in fact constitute more than 50% of all brain tumors that we deal with. Another important statistic is that as patients age, the incidence of meningiomas increases compared to other brain tumor types. And we know that the population is aging, and aging well. And so in all of our practices, we're seeing an increase in the number of meningiomas. And if we look at this world map, for those who are predicted to be in the percentage over 60 by 2050, you see that a significant proportion of the world will likely live a fairly longer life than previous, and so meningiomas become a more relevant brain tumor for us to manage. Majority of the talks in the morning have focused on how better to be able to distinguish and determine, prognosticate outcomes for meningiomas. What we currently rely on is histopathology, but there is a degree of subjectivity in that. And in particular, if you look at distinction between grade 2 from grade 3 meningioma, it relies very much on the number of mitoses per 10 high power field. And so there's a variability in this, and an inter-observer variability that's documented between 2 or more neuropathologists. There are 18 different subtypes under the microscope. Some are aesthetically pleasing. Majority of them otherwise don't have a bearing on clinical outcome for the patient. Some grade 2 meningiomas, clear cell and chondroid, and grade 3 papillary and rhabdoid perhaps are associated with unique features clinically for prognostication again, but nevertheless, I think we need better information than histopathology. Surgically, we still very much rely on Simpson grading, and as you know, Simpson grading was introduced over 3 decades ago with a CT-based assessment. It's rational in that it makes sense for if you have gross total resection, including the tumor, covering the dura, and the bony involvement, you get a grade 1 resection, with the likelihood of recurrence being low. However, all the way from grade 1, then you go to grade 5, where you're only able to obtain a biopsy, and of course that's a subtotal resection with a higher recurrence rate associated with it. This holds true. We tend to use it in our language in clinical day-to-day practice and in the literature. But ultimately, if we combine WHO grade and the Simpson grade, and you look at an institutional example, such as, for example, our own cohort, not all grade 1 meningiomas have a 0 recurrence rate, and there's a variability in time for recurrence. Grade 2 meningiomas, which I would say are the most controversial still, as there's significant debate as to whether we should give radiation. Some of that was presented earlier today, or withhold radiation. The range of outcome following resection, again, is quite wide. Again, grade 3 meningioma, I think most centers would accept that would have to have radiation following surgery. But again, in all of our practices, we have grade 3 meningiomas that in fact do not recur to any significance. And so we need to understand the biology of the tumor better, be able to come up with predictors and algorithms that can help us. I would say that if you look at brain tumor management in general, not just meningiomas, the paradigm for treatment is rather straightforward. A patient presents with a symptom and has a diagnosis on MRI. Based on that imaging, you could either go to surgical resection right away or continue surveillance imaging until features on the MRI change of concern or the patient's symptoms progress. Following surgical resection, the patient receives a histopathological diagnosis. For some tumors, mainly glial tumors, currently we use molecular features to refine the diagnosis and potentially guide therapeutic decision-making, such as IDH status, 1p19q, and MGMT. And then from there on, we go to rather standard chemotherapy and radiation modalities, with meningiomas really only having the option of either fractionated or focused radiosurgery. When this fails, we go on to clinical trials, and for meningiomas, the options of clinical trials are quite limited. If you look at histopathology, of course, there's approximately 150 different types described in the WHO classification, but we know from the glial field that in fact our understanding of tumors have evolved based on the molecular features I mentioned earlier. A significant contribution to the field, a landmark paper published in 2018, showed that methylation actually helps us refine diagnosis. This publication is from DKFZ group in Germany, Heidelberg, and they looked at approximately 3,000, and I understand since that time the numbers have increased to include nearly 10,000 tumors, where they analyzed by methylation of approximately 82 different brain tumor types. And you could see that the methylation signature on this t-SNE plot is very distinct for each different tumor type, akin to a fingerprint. So if you're an IDH mutant tumor compared to an IDH wild type, the methylation signature is very distinct. And in this publication, all comers, there was a 15% improvement in the classification, or in other words, accuracy of diagnosis, which is significant. So I want to show you perhaps methylation can in fact affect and impact our clinical decision-making in our day-to-day practice, and then build on that to show you how we've incorporated methylation beyond classification to be able to predict outcome for meningiomas in specific. And so where I think we can perhaps modify the paradigm is integrating methylation that would help us in decision-making for the brain tumor patients. I wanted to share with you our experience of integrating methylation into our clinical practice. And this was introduced, and I give credit to Ken Aldape, who at the time was a neuropathologist in Toronto. Between 2015 and 2018, we reviewed approximately the 1,700 cases that we analyzed, and we chose to focus on those that have a challenging diagnosis based on the criteria where 2 or more experienced neuropathologists could not reach consensus. We were having a discrepancy in what the clinician felt based on what they saw intraoperatively particularly, and the diagnosis reached by pathology, and molecular subtyping based on traditional methods was not possible or was inconclusive. And so of those 1,700 cases, we had 55 that were analyzed by methylation. And this is incorporated, and this is currently our workflow, where the patient receives a histopathological diagnosis. We use methylation-based classifier defined as and available through the DKFZ, copy number analysis based on methylation, and reevaluation of the histology and integration as a final integrated diagnosis. In our experience, the change in diagnosis was in 24% of the cases. A resolution of the differential diagnosis was in 31%. There was an upgrade of WHO classification in 18% and a downgrade in 5%, both very noteworthy numbers. We were able to assess and finalize IDH mutation status, 1p19q, and other molecular subtypes with the percentages that you see. If you look at the initial pathological diagnosis, using this integrated model and the crossover to the final diagnosis, you could see that there is significant crossover. And so improvement, perhaps, and refinement in the diagnosis was made possible. The next step was to say, well, does this in fact change the management for the patients? And these are examples where the initial treatment plan was determined based on histopathology and a new treatment plan that was devised following the integrated diagnosis using methylation. And you could see that, again, there's a significant crossover where, for example, fractionated radiation has been planned, but we then choose to observe and follow the patient. The most noteworthy is the one that I highlight in red, which is a young lady who had a seizure and had a surgery in an outside institution for a frontal glial tumor. The high-grade features were evident on pathology. However, 3 expert neuropathologists could not reach consensus. IDH status was intact, or in other words, negative for a mutation. And there were features that were concerning. However, the final diagnosis was glioma not otherwise specified. Based on imaging characteristics and the histopathology, the discussion at tumor board resulted in suggesting fractionated radiation and temozolomide. At this point, the father actually heard me give a presentation and asked whether we would do methylation. We in fact did methylation. The tumor was a DNET, a developmental neuroectodermal tumor. And as you know, that requires no additional treatment following surgery. And the patient was observed, and approximately 5 years later now, I'm delighted that the patient has had no recurrence, proving that the diagnosis based on methylation was accurate. And so really an impactful change in the management of a young person. In summary, based on our experience, we had an 84% change in the diagnostically challenging cases using methylation that was meaningful in the alteration of the diagnosis. 24% of them had a change in diagnostic entity, 31% had a resolution of the differential diagnosis, and 27% had a change in tumor grade. The area that we focused on, building on what was published from the DKFZ as well, is how does this impact clinical management of our patients? And 15% had a significant change in the decision-making of the treatment they received following following surgery. Excuse me, this is published in Clinical Epigenetics. The first authors are Shireen Karimi, who's a pathologist, Jeff Zuccato, who's a neurosurgery resident and a PhD student in my lab, finishing this year. And I want to give credit to Ken Aldape, as I mentioned, who introduced this program, and the Princess Margaret Cancer Center, who continues to help support the funding of this program, as currently we don't have ministry or government funding to support the methylation testing. So with that, I hope that I've shown you that in fact the application of methylation into brain tumor management and decision-making has been valuable. And in addition to improving the accuracy of diagnosis, it's allowed us to refine our decision-making for patients. What I'd like to show you then is, are we able to use these methylation signatures to determine outcome for patients and to improve diagnostic criteria? In order to study meningiomas, I think it's important to put together multiple institutions. And I apologize, the animation is not working, but behind the scene, you would have seen that we have formed an international consortium on meningioma. There's over 29 centers involved in this consortia. We participate in research studies, in particular genomic large-scale studies of samples that we can bring together from various institutions, and also focus on producing publications that allow us to raise awareness on meningiomas, advocate for the tumor in terms of research, funding, clinical guidelines, and neuroimaging in particular. Again, as we heard earlier today, some amazing talks that were presented. If we look at the literature on meningiomas, over about 2 decades ago now, there was a large-scale study, 2 in fact, that were published looking at mutational status on meningiomas to see whether there are defining mutations with increasing grades. You could see that in grade 1 meningiomas, there are recurring mutations that are now recognized. The NF2 mutation that we've always known about meningiomas as potentially a driver of growth and formation is evident in grade 1, 2, and 3. The limitation, however, is there are no recurrent mutations in grade 2 and grade 3 meningiomas. The limitation of this study, as I mentioned earlier, is that, of course, grade 3 tumors are rare, so if you rely on a single institution, the numbers represented here are small, and therefore this study is skewed towards the population where typically we're able to help by surgery. And so to focus on more aggressive, clinically aggressive meningiomas, pooling of the samples is necessary. The other feature that they looked at is the chromosomal abnormalities or copy number alterations or variations. There is an increase in copy number variation with increasing grade of meningiomas. As you know, those are not targetable, but do speak to potential aggression in the tumor behavior with increasing grade. Where we thought that we would look at in meningiomas is to look at methylation. And methylation arrays focus on predominantly CpG sites, and CpG sites, when methylated, in particular the promoter site, prevent activation of the gene in front of them and dysregulation of critical genes that are involved in cell death, cell cycle regulation, differentiation, and other, and of course contributes as a result to abnormal and aberrant growth of cells. In a study that we did originally in partnership with MD Anderson, we looked at a cohort of tumors and analyzed them by methylation to see whether there is any significant difference between the methylation patterns, and you could see that there are 2 distinct groups on the heat map. Associated with this distinct heat map pattern of methylation is a distinct difference in outcome for the patients. And this is independent of WHO grade, of the gender, of extent of resection, location of the tumor, or other critical features. We validated these results using a Toronto cohort, where again, based on the heat map, you could see that the methylation signature of one group is very distinct from the other. And again, the blue cohort have a favorable outcome and the red have not a favorable outcome. At the same time we were doing this study, the DKFZ group in Heidelberg did a similar study, and they defined 6 groups, though I argue perhaps the benign categories divided into 3 are the same, the intermediate and the more malignant, but lending evidence and support additionally to the data we have that methylation appears to be a defining signature for aggressive behavior of meningiomas. In their study, they layered, in addition to methylation, mutational burden, copy number alterations, and some of the histopathological features. We next thought, well, can we use methylation signatures to take this beyond the idea of diagnosis, accuracy in diagnosis, and to then individualize treatment for the patients or individualized predictability of the meningioma recurrence based on individual methylation signatures. We created a machine learning algorithm or a pipeline that allows us to predict individual meningioma outcome. How we did this is that we took an approximate 250 samples from different institutions and analyzed this by methylation and defined favorable and unfavorable cohorts and looked to see what probes distinguishes one from the other. And there's approximately 10,000 probes that distinguish favorable from unfavorable outcome. We then used those probes to generate a methylome-based predictor, a pipeline or a computer-generated pipeline that would allow us to use that same methylation signature to determine if one tumor is going to be a favorable or an unfavorable outcome. We validated that pipeline in 3 rounds of cohorts, and for the publication, we went to a 3rd cohort to ensure that in fact it held true and it was devoid of any biases based on the sample and the cohort population. We then were able to validate that the methylome with high accuracy could predict favorable and unfavorable outcome of approximately 80%. We layered that with various clinical factors, age of the patient, gender, WHO classification, extent of resection, etc. And through a multivariate analysis, we're able to identify key factors that contributed to being able to predict outcome for the patient in a 5-year recurrent-free survival. If you look at the same cohort of tumors that we analyzed, there's grade 1, 2, and 3 meningiomas based on WHO histopathology. If we apply that 10,000 probe-driven pipeline, the methylome-based predictor, to the same cohort of tumors, there are 3 distinct outcomes: favorable, intermediate, and poor. However, this is independent of the WHO grade because you could see that the lines are very different. In order to demonstrate that in fact it is independent of WHO grade and the methylation predictor overrides the WHO grade, we looked at each WHO grade category separately. In WHO grade 1 meningiomas, the methylome predictor certainly pulls out majority of the tumors to be favorable, but there is a subset, again as we see in our clinical practice, that don't have a favorable outcome, and the methylome predictor can pull this population out. WHO grade 2 tumors, again, the meningiomas have the most controversy around discussion at tumor boards as to what to do for meningioma grade 2. The methylome predictor shows that there is a wide range of this tumor type. There is an intermediate and a poor outcome, but there is a subset that do well, and I would propose to you that if you fall within this category for a WHO grade 2, withholding radiation would be suitable. And in fact, that's the sort of decision-making that we've now incorporated into our weekly tumor board. For grade 3 meningiomas, majority do poorly, but there's a subset that do very well. And again, we see this in our clinical practice. And once again, I would argue that if you're a meningioma that fall within this range based on the methylation, regardless of the WHO grading, you would then discuss as a group multidisciplinary to see whether we can safely avoid giving radiation to this patient. So how does the calculator work to make it individualized for the patient? The score of the calculator or the nomogram is weighed to 100% based on the methylome score that I said was a 10,000 probe-based methylation score. WHO grading did demonstrate a significance, but at approximately 50% of the weight of the score, and Simpson grading at approximately 20%. So for a hypothetical patient with a WHO grade 2, with a Simpson resection of 3, and a methylome score based on our pipeline of 0.6, the cumulative total points comes to approximately 90, and on the calculator, this gives you a 0.4, and the inverse of that, so 60% chance of recurrence at 5 years for the patient. We now use this nomogram in our daily practice. At tumor boards, we discuss the methylation predictor for meningiomas, in particular for the grade 2s and grade 3s, and grade 1s that have clinical features of concern for us. And so I think we've been able to refine the paradigm for treatment of meningiomas by integrating the nomogram at this stage. I want to show you some examples. There are no patient identifiers here. I just want to make that clarification. This is a meningioma that was resected from an outside institution. The WHO grade was 2. There's residual, so Simpson grade 4. The methylome-based predictor is 0.89. And using the calculator that I showed you, the 5-year recurrence score is 0.09. The inverse of this in 5 years is a higher number. And so in 33 months, we see that the tumor has recurred, and aggressively so. A comparable tumor with a grade 2 meningioma, a very good resection, Simpson grade 4. The methylome score, however, is much smaller than the last case. So the 5-year predictor, in fact, becomes a number that's the inverse of this and shows that the likelihood of recurrence is very low. And in fact, 72 months later, this image, and now an additional 24 months have passed approximately, there is no recurrence and this patient was given no radiation. What we're doing now moving forward, of course, is in addition to ensuring that we've integrated this into clinical practice with all the disciplines accepting it as valid and relevant to decision making, to keep a record of the cases that we decide to have radiation or not in a prospective manner, and also see whether we can design a similar predictor based on tumors that have been radiated and responded and radiated and not responded, because there is a difference in the methylation signature for those that respond to radiation and those that don't. This work was published in Neuro-Oncology, and as I mentioned, we've started to incorporate it into our clinical practice. What I wanted to speak to you next is where do we go from methylation? Because I showed you earlier that we looked in the literature, we look and see that whole exome analysis of meningiomas reveal mutational patterns, but really those recurrent mutations occur in grade 1 meningiomas. Recurrent mutations within grade 2 and 3s have not really been published to date. And so exome mutational data analysis does not seem to have the same impact as it does, for example, in gliomas, where IDH mutation is a defining feature of outcome for gliomas and a defining feature of our understanding of the biology of the tumor. There are additional platforms, of course, that we can analyze tumors. There's RNA, there's methylation that I showed you, and copy number analysis using either methylation or more accurately, whole exome sequencing. So which of the platforms are accurate and how do they compare? In order to answer the question, we took a cohort of approximately 200 samples, ensuring that they're enriched so that there's equal representation of grade 1, 2, and 3 as much as possible, and also taking into consideration knowing that WHO grade is not the sole predictor of outcome, those that would behave aggressively based on clinical behavior. And so those that would have recurred, regardless of the grade, within a period of 5 years, we call them clinically aggressive meningiomas, CAMs, and included that in this cohort. We made sure that we have a clean cohort. It acts as a resource for the community because the data is now made publicly available, and analyzed this approximate 200 tumors using different platforms. We analyzed with RNA analysis, methylation, copy number, whole exome, proteomics. What I'd like to show you is that if we use RNA clustering, the cohort of 200 tumors divide into 6 distinct clusters. And these are stable clusters. Regardless of parameters set for clustering, you can reproduce 6 different groups based on RNA expression data. It's important in that the 6 groups have very distinct outcomes, so there is a clinical relevance to it potentially. If we take the same cohort, now analyze it with methylation, you can again reproduce 6 clusters, and recall the DKFZ has 6 clusters as well. The outcome for each of the 6 clusters is different. There's a very good outcome, an intermediate, and poor outcome. If you take copy number analysis based on whole exome, you again get 6 stable clusters, and the outcomes are different. But as you can see from the outcome curves or the Kaplan-Meier curves, they're not similar. And so it suggests to you that obviously those 200 tumors analyzed based on the platform give you different clusters. And the question is, how do they correlate? So if we look at the methylation data, RNA and copy number on t-SNE plots, samples distribute based on their clusters. Cluster 6, for example, in methylation, is nowhere comparable to cluster 6 on RNA and nowhere comparable to cluster 6 in copy number variation, and similar to others. In fact, if you look at a plot where the crossover is documented, you could see that if you belong to the first cluster in methylation, it is not a one-to-one match for RNA nor to copy number, and there's significant degree of crossover. So the question is, which of the platforms is more accurate? Because obviously there's significant crossover. What is the most meaningful biologically that allows us to say RNA is better than copy number, or more accurate and biologically more rational? And the answer is, I believe, from the work that we've done through cluster of cluster analysis to combine and merge, layer the 3 different platforms together. So the cluster-of-cluster analysis was performed, and in so doing, we were able to use methylation, RNA sequencing, and copy number variation. Exome data, recall, are not recurrent and so difficult to, in fact, use them as clustering techniques for all types of meningiomas. And so these three platforms, cluster-of-cluster or COCA analysis, results in 4 stable, reproducible groups of meningiomas. Some rely on copy number and methylation more than other groups, and some rely on methylation and RNA. But regardless, there are 4 distinct groups that are reproduced independent of WHO grade, independent of extent of resection, to some extent independent of anatomical location, and no particular recurrent mutations, as I'll show you, or any other clinical demographics of the patient. With these 4 groups, so MG1 to MG4, there's a clinical relevance because, again, there's distinct outcomes, as you can see, with no crossover of the Kaplan-Meier curves, and MG1 being the most favorable outcome, MG4 being the worst prognosis outcome. If we look to see how cluster-of-cluster analysis, or the COCA groups, MG1 to MG4, perform against the methylation that I showed you earlier, or WHO grading, you could see that the performance based on COCA group is much better than performance based on methylation or WHO grading. And so it's a higher predictive capacity for MG1 to MG4. And then the next step was, is there a biological reason that these tumors are dividing into 4 categories? In order to explore that question, we looked at the RNA data and did pathway analysis and expression analysis and gene set enrichments. You could see that MG1 to 4, this is MG1, MG4, MG3, and MG2, end up revealing that there are distinct pathways involved in each of the classes. MG1 is concerned mainly with immunogenic pathways, MG4, cell cycle and proliferative pathways, with some crossover to the metabolic group, and MG3 are the hypermetabolic, where metabolic and angiogenic factors are upregulated and the pathways involved. And so we call the MG3 the metabolic, hypermetabolic, MG4 the proliferative, MG1 the immunogenic, and the most notable is MG2, where NF2 is in fact wild type. So until our study, we have always believed that NF2 mutation is a mainstay of meningiomas, whether it's a driver or a initiating factor. However, there's an MG2 category that shows that NF2 can be wild type. The mutational patterns that you could see, again, there are very few recurring mutations within the different groups, but there are notable mutations such as P10 mutation that was novel in our finding. By doing pathway analysis, you're able to also do a drug screen to see whether we can repurpose existing drugs. And most exciting is that we see verinostat targeting the MG4 tumors, and I'll show you some of the data on that. This result also points to the fact that when we're designing clinical trials, we would be able to then focus based on whether they're immunogenic, proliferative, and hypermetabolic, rather than grouping all meningiomas together or differentiating them based on grade. We could, on their biological definitions and rationale, designing clinical trials to target immune pathways, proliferative pathways, and metabolic pathways is most important if we use this categorization and the COCA analysis and subtyping. The next and most important question, of course, is that for every patient's tumor, in order to be able to get the MG classification or the COCA grading, it's prohibitive to do methylation, copy number, and RNA expression patterns. Is there a way that we can convert the results to a ready test that can be used in any institution's immunohistochemical lab? And the approach to that would, for us, be to use proteomics. We took the same approximate 200 tumors and analyzed them by proteomics, and you could see that they divide themselves based on and parallel to the MG groups into 1 through 4, and each of the 4 groups of meningiomas have a very distinct methylation subtype and a methylation, proteomic pattern. And there are distinct proteome signatures and also, more importantly, factors that distinguish one MG group to the other. So for example, MG1 can be identified with S100, with the other groups not staining, and so the accuracy of this is 0.84. SCGN is a factor that would identify MG2 with accuracy of 0.85, again, no staining of the other groups. ACADL identifies MG3 and MCM2 MG4. This, of course, needs to be validated in a blinded manner in a subsequent cohort in a distinct immunohistochemical lab. But nevertheless, the data has promising results to say that we can convert the MG1 through 4 into a histopathological test that can be used in any institution. In order to test whether the therapeutic, in fact, is genuine from our RNA pathway analysis and real for application as a translational component of this research, we created meningioma cell lines. One of the biggest restrictions in meningioma research is lack of availability to preclinical models, cell lines, and as a consequence, in vivo models. The cell lines that are typically available are established cell lines, ioma leads, and other that over time, in fact, have changed their phenotype and are not truly reflective of meningiomas. We took each category, MG1, 2, 3, and 4, and attempted to make lines out of each category from operative specimens. We're successfully able to create lines that are passageable from MG1, 3, and 4. MG2, which you recall are NF2 wild type, do not grow well in vitro. And so that line is not represented. MG1, 3, and 4 were treated in vitro by varinostat, and you could see that in fact MG4 has the most robust response to decrease in growth compared to MG1 and MG3. By comparison, when we use a more generic compound such as 5-azacitidine that's supposed to impact epigenetic changes, you can see that the 4 lines do not have any effect by 5-azacitidine. We tested varinostat in vivo. We grew the cell lines 1 through 4 as intracranial xenografts, and I show you the data for the MG4 lines where intracranial xenografts grown compared to control. Varinostat was able to decrease tumor growth as determined by MR imaging, and also increased survival with treatment of varinostat. So the stage that we're at with this part of the research is to in fact test it in clinical trials, and we're exploring whether we can in fact include also immune therapy in there. This work was published in September in Nature, and I have to thank the first author, Farshad Nassiri, who's a PhD student in my lab, in fact just completed his PhD, a neurosurgery resident completing his residency training, and the second authors, Jeff Liu, Vikas Patel, and Yasin Mamajan. 3 of them are bioinformatic members in my lab who do majority of the bioinformatic work that I've shown you. And a study such as this really is not made possible without multiple institutions, multiple outstanding collaborators, Paul Boutros, Gary Bader, Daniel DiCarvello, Tom Kisslinger, and Ken Aldape. This is the cartoon summary of what I've just mentioned to you, that meningiomas based on cluster of cluster analysis can be divided into 3 categories: immunogenic, NF2 wild type, hyperproliferative, and metabolic. There is some distinction between anatomical location, but I would say not significant. There is a clear distinct difference in outcome based on the groups and distinct biological relevance to each of the groups, with proteomically identified factors that can be used to stain the tumors in an immunohistochemical lab. And data that I haven't shown you is the single cell analysis that we did with meningiomas of all 4 categories that shows that the intratumoral heterogeneity is present, the intertumoral heterogeneity is not high, and at a single cell level, a lot of the biological features that we see relevant to each of the 4 categories is conserved. The next data set that I want to show you is, can we take the treatment paradigm that I've mentioned and modify the paradigm, enhance and improve it by adding liquid biopsy. And again, relevant to meningiomas, in particular for those that due to their eloquent and sometimes high-risk locations in the brain, we avoid biopsy or surgical resection and move them on to radiosurgery. So for example, the most notable would be cavernous sinus meningiomas that are well-defined in size. At our institution, at least, typically they go on to radiosurgery, but we never know the grade. So can liquid biopsy help? And this portion of the talk, of course, talks about liquid biopsy as it pertains to brain tumors, but I'll show you some specifics related to meningiomas. We know that tumor cells shed small pieces of DNA into the circulation, and the tumor pieces can be captured and as a consequence examined to use it as a predictive test, as a diagnostic test, and potentially as a determinant of response to therapy. Majority of the work done on circulating tumor DNA has been on mutations. The challenge with that is that the recurring mutations is very small, and in particular, as I showed you again, recurring mutations between grades is very limited for meningiomas. But in a tumor, the likelihood that a piece of DNA contains a mutation that is diagnostic and characteristic of the tumor is low. And so the low abundance results in a situation where it's like finding a needle in a haystack. In order to mitigate this, we thought perhaps epigenetics as a conserved entity within the DNA allows us to then more accurately diagnose brain tumors. This, of course, is mitigating the needle in the haystack approach and provides us with an alternative opportunity, merging it with the data that I've already shown you on our understanding of methylation in brain tumors, creating an exciting and unique opportunity. The work is really credited to my senior colleague and scientist, Daniel DiCarvello. He published a seminal paper in Nature in 2018, where they looked at solid cancer and compared the tumor methylation to the circulating cell-free DNA methylation and compared that to normal plasma from volunteers. You could see that the methylation signature in healthy candidates compared to, for example, in this illustration, pancreatic cancer is very different. And similarly, that methylation signature is conserved in the plasma of that patient compared to the plasma of normal. And you can see on the volcano plot that the points of methylation are very distinct between tumor and normal circulation, or sorry, circulation from the patient with the cancer. They also then extended that finding to a number of solid tumors and AML. AML is a liquid cancer, of course. You have 100% accuracy in being able to distinguish the methylation signature in the circulation from the DNA of the tumor compared to normal. They showed this in breast cancer, lung cancer, pancreatic, renal, etc. And comparing to normal, you could see that you can distinguish these cancer types with high accuracy from normal plasma. We then thought that maybe we can apply this to brain tumor diagnosis as a novel approach and look at circulating tumor DNA and methylation signature and see whether, in fact, given that we have the wealth of methylation data on our brain tumor patients, we can identify the same signature in the circulation and take it one step further. Is the methylation signature that is predictive of outcome that I showed you, for example, for meningiomas, can that be captured in the circulation? And that will be revolutionary in what we do for brain tumors. The first question was, can we in fact detect sufficient circulating tumor DNA to be able to analyze the methylation? And can we use the signatures to discriminate between one tumor type versus the other? This is a cartoon illustration of the pull-down technique of the circulating pieces of DNA, followed by Sanger sequencing bisulfite conversion methylation. And we were able to analyze first gliomas compared to all other cancers, and we analyzed approximately 500 samples and compared also to healthy plasma. You could see that we can distinguish gliomas from all other cancers with an extremely high accuracy. And this is from circulating tumor DNA captured and analyzed for methylation. We next asked, can we distinguish IDH mutation and IDH wild-type gliomas to the same level? And in fact, you could see that IDH mutant and IDH wild-type with very high accuracy can be distinguished from other cancer types. Our next postulate was that perhaps gliomas that are higher grade lend themselves better to shedding of DNA and as a consequence, a more accurate diagnosis. But in fact, you could see that grade 2 and 3, where presumably the blood-brain barrier is intact, have an equal degree of accuracy compared to grade 4, and I would say, in fact, a more cleaner signal compared to grade 4, and I'll show you some of the data here. This is a heat map of the similar results where you could see that the brain tumors have a distinct methylation signature from all other cancers, and a plot of the same heat map that shows brain cancer signature. Of course, depending on the subtype of the tumor, the methylation will change, but nevertheless, all of them are very different from all other cancers in methylation signature on the circulating tumor DNA pieces. The next question we had is the signature that we're picking up in the plasma in fact coming from the glioma cells itself? Because it could be a consequence of multiple other factors such as treatment-related or tumor microenvironmental factors or circulating cells that carry a methylation signature that's different. And so maybe the methylation signature we're detecting is in fact not from cancer cells themselves. What we did is that we took glioma cell lines and analyzed them by methylation compared to other cell lines, other cancer cells. And you can see that the methylation signature is distinct in glioma lines. We then applied this to our circulating tumor DNA, and you can see, in fact, that it pulls out the circulating tumor DNA methylation in an extremely distinctive manner from other cancer types. So confirming that the signature we're picking up in the circulation of brain tumor patients, in this case gliomas, is very accurate compared to other cancer types and healthy population. What's very interesting is we included meningiomas, hemangioparasitomas, and the accuracy with which we can distinguish meningiomas and hemangioparasitomas from glial-based tumors is in fact higher. And so giving us some degree of reassurance, but also an exciting avenue to be able to use circulating tumor DNA to not only distinguish and diagnose, confirm the diagnosis of meningiomas, but more importantly, refining what we're working on, the grading and the possibility of translating the predictive modeling that I showed you based on tumor DNA methylation to the circulating tumor DNA methylation. Meningiomas in this plot are the darker yellow, and you could see that they form a tighter group together for their methylation signature compared to the other tumor types. This work was published in Nature Medicine in 2019. Farshad Nassiri, Ankur Chakraborty are the co-first authors. Daniel De Carvalho is my senior colleague who I referred to and thank for his collaboration. And it was really made possible for us to be able to make a big difference in contributing to circulating tumor DNA literature. And the work that we have ongoing includes approximately 700 different brain tumor types that we've analyzed and are hoping to create a predictive modeling based on the plasma signatures. I just want to give a shout out to our neurosurgery residents. It's really my pride to be able to have a large group of residents, an extremely talented group of residents. These are some images or pictures of them. They keep me very young, energetic, and active in my day-to-day interactions with them. And I really want to thank you again for the invitation, the granting agencies that supported this work, and leave some time for perhaps questions. Thank you again for the opportunity.
That was an amazing talk, and it kind of shows where the future of treating meningioma lies. And it's an impressive amount of work that went into creating these classification system, and it's truly impressive.
Thank you. That's very nice of you. Thank you.
I couldn't be more blown away, Dr. Zeta. You guys are redefining how we're thinking about this. I can't wait for our panel discussion. I know many of our other panelists from this morning have a lot of questions just with texting back and forth during your talk. This was just absolutely amazing and inspiring. So
Thank you.
thank you. Yeah, thank you so much. This is just great.
Thank you very much.
And I hope you stay on for our panel discussion. But
Yes, I'll just turn my features off.
Sounds good.
Thank you.
Thank you. And with that, we'll move to our next presenter. Our next presenter is a colleague of mine, Dr. Jeffrey Helgager. Dr. Helgager is an assistant professor of pathology at UW-Madison. His primary research and clinical interest lies in neuropathology, especially advanced molecular diagnostic. And today he's going to discuss the pathological nuances of meningioma diagnosis. And I think it's a great transition from Dr. Zeta's talk to his perspective on histopathology for meningioma.
Can you hear me okay?
Yep.
Okay, sounds good. And see if I can share my screen. Okay. Are we all set, more or less? Sorry, can you?
Yeah, it looks good.
Okay, good.
Yes, I can hear.
And you can hear me. Okay, good. Thank you. So I'm basically one of two neuropathologists at University of Wisconsin. And so I realized I was invited here basically to talk to a multidisciplinary group, obviously predominantly clinical, about pathology of meningiomas. And so this is obviously like a huge topic, and you could talk a lot about it. But I thought that I'd really focus on sort of the elements of this that would most inform, patient care kind of from a practical perspective in our current day, and so basically with that in mind, I'm going to focus mostly on relevant parameters in terms of diagnosing meningiomas, as well as the histologic and molecular parameters that will inform grade. And so that's basically what I'm going to try to focus on here today. And so I had a couple disclosures that have nothing to do with what I do at University of Wisconsin. So anyway, in neuropathology, obviously, most of what I do on a day-to-day basis, it's accurate diagnosis and grading of CNS tumors. And so, of course, this might be obvious. So, okay, so meningiomas are the most common primary CNS tumor in adults. And so this really underscores just how frequently, I see these and make these diagnoses. So it's a lot of what I do on a daily basis. And it may be obvious, but, why does pathology diagnosis and grade actually matter? So of course, diagnosis, we really want to be sure that we differentiate meningiomas from other neoplasms or even non-neoplastic processes of the meninges, which may, of course, have a very different prognostic and treatment strategy. So for example, the other day, I got a case and there's some suspicion it might be meningioma, but it actually turned out to be sarcoidosis. So obviously that has a very different implication than if it were a tumor. So we have to be able to figure that out. And that's really the objective evidence there in the pathology and the histopathology. And then grade, and this was definitely alluded to by previous speakers, particularly the last one, but there's a tight, though imperfect correlation with meningioma grade based on our current histologic parameters, recurrent risk, and overall survival. And grade assignment really dictates treatment strategies. So it's important when I'm making a diagnosis, of a grade 2 that I've really been sure that I have a good footing to stand on, that I'm making that diagnosis, because the patient's probably going to go on, at least at my institution, to receive radiation therapy. So I want to be sure that, that's really warranted. And then on the other hand, if I'm making a diagnosis of a grade 1 meningioma, I want to be sure that I'm not missing something that really should upgrade the patient, histologically to a grade 2, because then they won't receive the adequate treatment that they need. So it's actually, it's a big deal in terms of assigning the grades. And I will say that grade 3s are actually easier just because histologically they're usually quite straightforward in terms of being outright, malignant. So you can be pretty confident about that, but it's really frequently the grade 1s and 2s that need a little additional work. And traditionally, and this is actually really where we're standing mostly today, diagnosis and grade have been made off histologic parameters only. But definitely, and as we just saw, our understanding of molecular alterations dictating meningioma aggressiveness has been improving rapidly. And I really hope that that's something that we can further integrate at the University of Wisconsin. And I think, this is where we're going. And, it'll be interesting to see where we are, practically in 10 years of what the standard of care is, because this is evolving very rapidly. And beginning with the 2021 edition, or version 5 of the WHO classification of tumors of the central nervous system, and this is basically our manual for how we go about grading tumors, on a both the histologic and molecular level in CNS tumors. There's now been certain molecular alterations that are now sufficient for a diagnosis of a high-grade or anaplastic meningioma that have been incorporated into this diagnostic algorithm. And undoubtedly, this is going to. This is actually pretty rudimentary at this point, as you probably just saw. The parameters are pretty straightforward, but undoubtedly, with future iterations of this, there's going to be a lot more molecular parameters that are integrated in terms of determining specific grade and basically aggressiveness, which is what grade is a surrogate for. So with that, I'll just get into a little bit of diagnostic histology of meningiomas, and you'll get to see some micrographs, which is kind of nice. That's a lot of what I deal with. So, and this is just a gross specimen of a meningioma here. Actually, probably just an old Kodachrome, but you can see the way that they appear, this sort of fleshy appearance on cut section. This one comes complete with a dural tail. And in this case, one thing to note, of course, they're quite circumscribed. So they're just pushing into the brain, but not obviously invading into it. And in this case, significant mass effect as a result of this tumor. And then this is just on basically histology. And so these are, I'm going to show two basically of the most common sort of histologic subtypes that one would encounter when looking at these. And so this is a meningothelial meningioma, which is more common at the skull base, just straight from the 2021 WHO classification. And they characteristically have this sort of lobulated appearance, very syncytial. And then the nuclei also have frequently this glassy cytoplasm, which is a good basically diagnostic parameter. So once you look at a lot of these, you can look at them and without doing any stains or anything else, you're really quite confident that you're dealing with a meningioma. This is a fibroblastic meningioma, and these are more common at the convexity. Importantly, they're more commonly associated with NF2 mutations. And they can also be diagnostically a little bit more confusing. They can be confused for things like schwannomas as well as solitary fibrous tumors. But they have this characteristically fascicular appearance to them, which is a bit different than what you just saw with the meningothelial appearance. But frequently, they're the ones that you'll encounter are actually best classified as transitional. So they have components of both meningothelial and fibroblastic. And then another good feature to basically cue into are these simomatous calcifications. So they look basically like, I guess, tree trunks that have been cut through. You get these sort of, I guess, just calcifications here that have this sort of annular appearance to them. And when you see that, there's few tumors within the meninges that would actually have that, except for meningiomas. So when you see that, you can be pretty confident that that's what you're dealing with. And then this is, if they're really well developed, you'll call them a simomatous meningioma, and they're the most common in the spine. So that's usually where you see those. And as was alluded to before, there's at least 13 more meningioma histologies that have been described. And some of them have kind of some unique molecular alterations. So for example, angiomatous meningioma has frequently multiple polysomies, and then secretory meningioma has a unique molecular profile to it. But actually, for all practical purposes, they've been described, but they don't really have any implications in terms of aggressiveness or grading. Certainly like angiomatous and secretory actually are more commonly associated with brain edema. But beyond that, there's not really a lot of other implications. So I'm not usually generally when I'm, issuing a pathology report, all that concerned about the specifics of the unique histologies that these have. But there are a couple of histologies that are important. So that would be these over here, and I'll get into these a little bit more. And they, by default, if they're well developed in terms of their histologies, are sufficient to establish a grade 2 or grade 3 diagnosis. So with that, I'll get a little bit into grading, and then I'll keep this pretty practical in terms of the implications for a pathology report today. But there's three grades, as you probably all know. Grade 1 is benign, grade 2 is atypical, and then grade 3 is going to be anaplastic. And the vast majority of these, as you can see, about 75% are going to be benign. And then the last fifth to a quarter, depending on the data set you look at, is going to be atypical. And then really the vast minority of tumors that you encounter, and there's just not that many of them, are going to be grade 3s. And it's important to just keep in mind that, despite these tumors being more prevalent in females, it's actually when you get out of that more common demographic range that you'll more commonly see the grade 2s and 3s. So in males, they're going to be more enriched for grade 2s. And then same thing for the pediatric populations. You rarely should encounter meningiomas in pediatric populations, but if you do, and they're honestly, generally molecularly distinct from adult tumors, but they're more likely to be grade 2 or 3 tumors. And so this is just showing, the very practical relevance of grading. This is a somewhat older paper, but it's looking at just a cohort of patients with grade 1, 2, and 3 meningiomas. And you can see that progression-free survival and overall survival as you progress from benign to anaplastic goes down considerably in terms of, the survival and progression-free survival. And I looked recently, just at a cohort relatively small of patients in our archives at University of Wisconsin of anaplastic meningiomas, for example, and this was probably over a 10 to 15 year period. And, basically nearly all of them, unfortunately, were deceased. So it's pretty bad by the time it gets to grade 3. So it's important to identify that and know that for prognosis and treatment. So just getting really just into the nitty gritty of how on a day-to-day basis I'd go about classifying these, but you see this in a pathology report if you're ever dealing with a pathology report. So I think it's important to understand, kind of what goes into generating it. So traditionally, of course, grading has been histologic, and that's still what we predominantly rely on at present times here. And the most important criteria is mitotic count, as I think was emphasized before. So even focally elevated mitoses are enough to achieve a higher grade. And this is actually important because, if you have, let's say, 30 slides of a meningioma, it's very important that you go through and, really scour to be sure you're not missing areas that may be elevated, because even a focal elevation would be enough to get you to a grade 2 based on our current grading systems. So mitoses less than 4 per 10 high power fields is a grade 1. You get to between 4 to 20. And that's grade 2, and then greater than 20 is going to be grade 3. And that is actually, to me, the most important set of criteria that I can use to grade. There's other histologic criteria that we can use to actually get up to grade 2, and that would be increased cellularity, sheet-like growth, prominent nucleoli, small cell change, or spontaneous necrosis. And if you get at least 3 of those features, it's an automatic grade 2. But I just want to emphasize, and this is, again, where, molecular is really important, that these criteria are actually subjective histologically, and there's a lot of intra-observer variability between these. So you really want to be careful, and I'm very careful about diagnosing a higher grade just on those criteria alone. I really want to see elevated proliferation before I do that. And so that's just something to keep in mind. And that might be, with the one exception, would be spontaneous necrosis, which is pretty objective. Brain invasion, again, when definitive, is going to be sufficient for a grade 2 diagnosis. And so this here is just showing increased mitotic activity. So you can see here in this particular meningioma, just in one field, we have a whole bunch of mitoses. And this would, if you replicated this throughout 10 high power fields, you'd be basically up to a grade 3. And then I just wanted to basically briefly touch on MIB1 proliferative index, which I think had been talked about a little bit just in passing. But this is an antibody clone against the protein Ki67. And it's basically just an immunohistochemical stain, but it labels any cell that's not in the G0 phase of the cell cycle. So any cell that's proliferating is going to basically light up with this. We routinely order it on meningiomas to guide as well as corroborate our mitotic count. So it's nice if you aren't getting many mitoses, and let's say that this MIB1 ends up being, really elevated. You want to take a second look at your tumor to be sure you're not missing mitotic counts, because there's a discrepancy there, and conversely, if it's the other way around. So it can be a helpful aid. And it's a MIB1 proliferative index. When you see this in reports, it's simply the percent of MIB1 positive nuclei over total nuclei. Sometimes it's estimated. Actually, that's the majority of times. But if I really have a specific question, let's say it's right on the cusp between a grade 1 and a 2, and I want to report a very specific figure, I'll go back and I'll count, 600 to 1,000 cells and just come up with what my percentage may be. It can't be used for formal grading purposes for various reasons, but studies have suggested that meningiomas with indexes of greater than 4% may be more aggressive with recurrent rates similar to grade 2 meningiomas. So with that in mind, when I do this, and if I'm right at the cusp, let's say I have a grade 1, it doesn't have a lot of mitotic activity in it, it doesn't have many atypical features, but MIB1 looks elevated. And if I quantify it and it's above 4%, I'm going to report it out as meningioma CNS WHO grade 1 with elevated MIB1 proliferative index. And I don't necessarily know what all you do on that end, but I'm hoping that it is an asterisk or a red flag that may lead you to believe that possibly this tumor should be followed more closely. It may be more aggressive. And my understanding is the major pitfalls of using this for grading purposes is there's a lot of intralaboratory variability in terms of the way it performs. So it's difficult to replicate between institutions and come up with stringent, guidelines. And so this is just a MIB1 proliferative index here, just to show you what this looks like. So this would be on the left, you have something that's consistent with a grade 1, less than 1%. So basically these cells here are proliferating. And there's not very many of them. Then you get to about 10% in the middle, and then 40% on the right. And so this would be consistent with a grade 3. The middle is more consistent with a grade 2. Okay, and then just some atypical grading features. So these are macronucleoli. You can see the nucleus here has this prominent nucleoli in it. And when you see that, that would basically qualify as a macronucleolus. Then this is sheet-like growth right here. So you can see it's lost its lobulated architecture. Small cell change, increased nuclear to cytoplasmic ratio. And you can see that over here on the left better. And then this is pretty straightforward to see just in terms of spontaneous necrosis. Almost looks a little bit like palisading necrosis in a GBM. But when you see that, that's actually, for me, the worst atypical feature that can be detected. And so I really want to study these hard to be sure that there aren't other features that would take me up to at least atypical if I'm not seeing them immediately, because usually the ones that have spontaneous necrosis in them aren't good. This is just brain invasion, another grade 2 feature. You can see these basically islands of meningioma in central nervous system tissue here. And again, a tongue of meningioma extending down into brain. This is an anaplastic meningioma just with a lot of hypercellularity and small cell change, as well as sheet-like growth. But you can see it really doesn't even resemble a meningioma anymore. Once you get to this level, if I just told you it was a sarcoma, a high-grade sarcoma, I couldn't necessarily tell you. And this is just frank anaplasia in a grade 3 meningioma. Again, you frequently see not just mitotic activity, but actually atypical mitotic figures. So these cells are presumably aneuploid, so they're just not able to mitose correctly anymore. And so you have, multiple chromosome sets coming apart and whatnot. And so that's why you see these as atypical meningiomas, or atypical mitoses rather, sorry. And then some meningiomas have distinct histologic subtypes, as we discussed, which in and of themselves dictate a higher grade. And so that's now, you can see over on my chart here in red, but grade 2 choroid meningioma and clear cell meningioma. And then grade 3s are papillary meningiomas and rhabdoid meningiomas. And just as a caveat with this, just as with atypical grading features, these histologic subtypes can be somewhat subjective. So you need to be sure that they're well developed in order to really make the diagnosis. And actually, this is most important really for grade 2. And I'd say choroid meningiomas are probably the most challenging because they don't even have any molecular features really that I'm aware of that have been reliably present in these sorts of tumors. So you really have to do it histologically, to my knowledge. 2P loss has been one thing people have reported, but it's not always all that consistent. This is particularly, yes, it's particularly important that these be well developed. For the grade 3s, though, usually they're outright anaplastic already, and there's been data showing that unless they're looking outright anaplastic, even with well-developed histologic features of like papillary or rhabdoid, probably calling them grade 3 is not good, and they should be graded independently of their histologies and just graded based on the mitotic activity as well as atypical features. But frequently, like when you get something that's a rhabdoid meningioma or looks like a rhabdoid meningioma, it's going to have mitotic activity that's almost basically fulfilling criteria for a grade 3 tumor already. And there's growing evidence that there are defining molecular alterations which dictate these histologic subtypes and increased aggressiveness. And so you really want to try, these can be clinically looked at, and you really want to try to, if possible, use these to back up your diagnosis whenever you can. So this is a choroid meningioma, and it has this prominent mucoid matrix in the background. Hopefully you can appreciate it. And it doesn't really look much like a meningioma. Either it's lost its sort of lobulations and some of the nuclear features, another choroid meningioma. This is a clear cell meningioma, and it's not just clear cells, but it's actually this ropey collagen that's important to see, and then somewhat with the nuclei as well, losing their more meningeal appearance to them. And you can see, so here's clear cells. These are interesting tumors. They're more common at the CP angle as well as the cauda equina. And sometimes you'll see tumors that have a little bit of clear cell change to them, but what you really want to see, if you can, to back up your diagnosis, is to show SMARC-E1 protein loss in them. And this is basically, it's a protein in the SWI/SNF pathway, and it's a tumor suppressor gene. And so when this is lost, this is basically invariably lost in clear cell meningiomas. And there's actually families that have syndromes where they have germline mutations in SMARC-E1. So if I were to ever pick up one of these, as I did one time so far in here at University of Wisconsin, if I were to ever pick up one of these, I would want to try to see, make sure the clinician was aware to possibly send this patient for genetic counseling, just because they may have a germline syndrome. And let's see, then finally, rhabdoid meningioma and papillary meningioma. So these are grade 3 by default. There's some histologic overlap between these entities as well as molecular overlap, which is interesting, but they're both exceedingly rare. At least a subset of tumors have mutations in BAP1 tumor suppressor gene, resulting in loss of BAP1 protein expression. And this is particularly true for rhabdoid meningiomas. This can be assayed readily by IHC. So if you have a question, you can actually get BAP1. We have it in at University of Wisconsin. We can run it. More recently, PBRM1 inactivating mutations have also been identified in both predominantly papillary, but also rhabdoid meningiomas, and they can actually occur together, PBRM1 and BAP1 mutations. Both genes are on chromosome 3p, and they may occur in conjunction with 3p loss of heterozygosity, which is usually what happens. And then again, so there's our tumor predisposition syndrome. The majority of patients that have germline BAP1 mutations, which is what one would see in these patients that have a predisposition towards rhabdoid tumors. Actually, most of them would probably present with melanoma or mesothelioma. It's actually a minority of patients that get meningiomas, but if you see a meningioma that does have this mutation in it, you'd again want to get genetic counseling because it is a inherited, basically, disorder. So this is a rhabdoid meningioma, kind of more glassy cytoplasm with some inclusions in it, which kind of make it rhabdoid. Basically, they have more of an epithelioid look to them in some ways, and then mitotic activity as well. This is BAP1, and the patient that was just the figure I showed you, but BAP1 is lost in this particular tumor. That's not always the case in rhabdoid meningiomas, but it's a subset of them. And then papillary meningioma, so basically this papillary architecture with some anaplastic features as well. Both of these are, again, exceedingly rare. And then finally, the last sort of parameters I want to discuss, and these are the only molecular parameters we're now using. And this is basically new just to the grading criteria in the 2021 edition, which we've only had for a few months now. So you can see up until this point, we really haven't had any, as standard molecular findings that would actually, make a diagnosis or make a grade. It was all histologic. So this is, it's very slowly coming. But now, basically, if you have two particular alterations, so presence of TERT promoter mutations, and these are usually the canonical mutations that one sees that activate the TERT gene. And then CDKN2A, 2B homozygous deletion is also going to be sufficient for designation of grade 3. So TERT encodes telomerates, it maintains telomere length, and it's usually one of these two mutations that I'm showing right here. And then CDKN2A, 2B tumor suppressor. So these are genes that are in the RB pathway, and they control cell proliferation. And so basically when one finds these, you're now entitled to call this, and you would call it a grade 3 tumor. So how do we actually, now that I've talked about some of the molecular changes that would actually inform our grading and actually dictate our grade, how do we actually pick these up clinically? So at a clinical level these days, what we can do, I'm going to talk about 2 different assays, so targeted next generation sequencing, as well as chromosomal microarray. And so targeted next generation sequencing, this is basically a targeted exome DNA sequencing assay, which sequences genes known to be important in oncogenesis. And the number of genes that sequencing, depending on the platform you're using and et cetera, it keeps increasing, as it's further developed. Right now, what we use has about 650 genes that are looked at. And it also sequences select non-exome regions, for example, TRP promoters. So that's important. We'd need to have that. The other thing that's important to know, it can detect gene deletions and amplifications on a semi-quantitative basis. So for example, CDKN2A2B deep deletions would be found generally on this. And many platforms also incorporate RNA-seq technology, which can detect gene fusion events. And this usually isn't so pertinent to meningiomas just because they don't usually have gene fusions, but it's definitely helpful, and it's certainly helpful in gliomas. And so right now, just from a very practical level, we're outsourcing to Tempus right now, so this is industry essentially. We don't have our own in-house sequencing assay for various reasons. But given implications of the select molecular alterations that we may find for grading, we send for next generation sequencing on meningiomas basically with histologic grade 2 diagnoses or above. So that's sort of been our policy so far. Then I do want to talk about chromosomal microarray. And actually, what's interesting is we were talking about methylation earlier, and methylation assays actually also get out copy number variations. So it can be very important, not just for the methylation score that you get, but also for the copy number variations that can be informative if you were to use methylation. The reason I haven't talked as much about this is because right now, at least at present, these methylation assays are basically only at select institutions across the country, and you have to really make an effort to send out to them, and they're expensive. So we just haven't had the opportunity to employ them that much, but I think that that's something that in the future we'll definitely be looking at. But chromosomal microarray just looks at copy number variations, and so it detects chromosomal copy number changes in tumors, gains, losses, and amplifications. What's to note about this is it's more sensitive, specific, and quantitative than next generation sequencing. So it can be helpful if you're specifically wanting to analyze copy number variations. And though NGS is generally sufficient for detection of CDKN2A2B homozygous deletions, it's important to note, and this was alluded to in the previous talk quite a bit, that meningiomas are notable for accumulation of chromosomal copy number changes as they undergo malignant progression. And this makes this technique particularly attractive to employ in this tumor type. And actually at the institution that I trained at, we routinely did both NGS and array on meningiomas because they basically complemented each other in terms of trying to inform potential aggressiveness, even though at that time, nothing in the molecular was actually a formal grading feature in terms of what we would do with it, but it would help to inform our grade. And this is not currently employed at UW for meningiomas. So those are some of the molecular techniques that we can use to try to detect some of the new molecular features that we're using for grading. And I thought it would just be important because I think this was touched upon a little bit in potential learning objectives, but this is now we're trying to move from just a simple pathology report to pathology report that isn't just a final diagnosis, but it integrates basically histologic and then also molecular data in its sort of final integrated form. So it's called an integrated diagnosis. And so this here is just an example, kind of a hypothetical example I put together of what an integrated diagnosis would look like. And basically everything I just have talked about and told you, we have our basically our grading criteria that are stated in the comments. So now that I've shown some of these to you, maybe the next time you're looking at a pathology report, you'll have a better understanding of what exactly these grading criteria entail and how they were determined. But this would be an integrated diagnosis for a rhabdoid meningioma, CNS WHO grade 3 here. And so presumably it had, prominent rhabdoid features, but then it would have had a BAP1 mutation in this particular case detected by NGS. with chromosome 3p loss by microarray, which, another ancillary sort of complementary test that would have been done in this case. Then another high-grade mutation, p53 mutant, and then multiple polysomies, which would also support something that's higher grade. And then you can see here, in the comment, the atypical features and brain invasion being present, as well as an elevated MIB1 proliferative index. So let's see here. And I guess this was really already talked upon at great length by the prior speaker, but I'll just give kind of my own slant quickly here on future directions in terms of molecular on meningiomas. And so, as was stated, there's this observation that obviously a minority of grade 1 meningiomas just recur, despite the histologic features that would suggest otherwise. And then also, on the other side of that, some grade 2s are less aggressive, and so how might molecular alterations further inform meningioma grade? And I'll say, all the molecular alterations I just told you about, the two that actually are formally used for grading criteria, aren't really going to get you between grade 1 and grade 2 meningioma so much. And that's actually where the important distinction probably lies most in terms of treatment. So anyway, recurrent genetic changes classify the majority of meningiomas. And so there's actually, I guess if I had to look most superficially, just in terms of mutations that one finds in these tumors, there's really two big groups. And so the largest group usually has NF2 mutations in it. And so, the fibrous meningiomas that I just talked about. And those could comprise as many as 60% of tumors, depending on the data set you want to look at. And so usually there's going to be NF2 mutations, and this is usually in combination with loss of heterozygosity at chromosome 22, so monosomy 22q. And then the second largest group usually have TRAF7 mutations in them, though they can have some other things in them as well, independent of TRAF7. So PIK3CA, SMO is another one that can be encountered. And they're more likely to be benign, and they also usually are more stable in terms of their copy numbers. So the tumors with the NF2 mutations are most likely to progress, developing chromosomal copy number changes and genomic instability. So the most common thing you'll see, as I said, loss of 22q, and that's usually compatible with just a grade 1. But then as they progress, you'll find that other things start to happen. So you can have 1p loss, which is really a harbinger of more aggressive behavior. And then 14q loss, I guess, is the third most common. But there's ultimately many different karyotypic changes that can occur as these tumors basically become more atypical. And so this is an older paper here, but it's just showing that in grade 1s, histologic grade 1s, the majority aren't going to have very many karyotypic alterations, but as you get up to grade 3, now the majority of them have, quite a few karyotypic abnormalities in them. And so basically there's an association here between grade and karyotypic abnormalities, and that grade was just made on histologic, basically diagnosis alone. So more chromosomal copy number changes are associated with higher grade. And so this is just sort of to look at one thing that was done here, just in terms of copy number alteration, and how might this inform grading. So this was just a large study that was done, and it looked at 527 meningiomas and looked at chromosomal copy number alterations in them, and then also stratified by histologic grade. And so you can see here that in grade 1 meningiomas, the vast majority of them don't really have very much going on at all. Some of them are going to have 22q loss, for example. And then as you get into the grade 2s and the grade 3, there's definitely more happening. But nonetheless, you can see that even in some grade 1 meningiomas, they do have this high risk 1p loss, for example. And so that would definitely be indicative that they probably do, and indeed they do have a higher risk of recurring. And then in grade 2, there's a subset that don't really have very much going on in them, and so they may be actually more on the lines of grade 1. So basically, present research in this area is focused on developing grading schemes that better incorporate both histologic and molecular data for better prognostication. And certainly our previous speaker talked a lot more about this, but I think it's really a matter of overlapping, histology, but then also multiple, ideally, finally, multiple different techniques to try to molecular techniques to try to inform grading. And so this really underscores, at least practically now, both NGS use and then also a robust readout for copy number variation in pathologic analysis of meningioma on a practical level. And undoubtedly, these molecular techniques will become more routinely used in their parameters incorporated into future grading schemes, including hopefully, even methylation data down the line. So I have some conclusions and key points here. I'm over time, so I think I can just stop here, but hopefully this has been informative just in terms of sort of practical everyday diagnosis and grading of meningiomas and in their pathology. So thank you.
Thanks, Jeff. That was a great presentation, and it gives a great overview of the breadth of this disease that we treat. So that was a very nice talk.
Thanks.
And next, I would like to introduce our last speaker, but definitely not the least, Dr. Michael McDermott. Dr. McDermott is a neurosurgeon and is the Chief of Medical Executive of Miami Neuroscience Institute. He's a world-renowned leader in neurosciences with clinical expertise in field of meningioma surgery and gamma knife radiosurgery. Today, however, he's going to talk about one of the most important aspects of all disease management, which is patients' quality of life. As physicians, everything we do is to improve the quality of life of our patients. And there's no one who highlights this aspect more eloquently as Dr. McDermott. But most importantly, Dr. McDermott always keeps me at the edge of my seat, and I wouldn't expect anything else about this talk. So with that, Dr. McDermott. You're muted, Dr. McDermott.
McDermott, I was able to unmute you, so if you're ready.
Okay, great. All right, thank you. Yeah, I made the mistake of once I shared my screen, I was blocked out, so I couldn't control audio. Do you see the screen now?
Yep.
All right, and let me just see. Okay, so yeah, this is probably the least sexy talk in neuro-oncology is quality of life, but it's something that's usually ignored by most surgeons, including me, on regular follow-up for tumor patients. This is my disclosure slide as listed on the website. And usually when surgeons are dealing with meningioma patients, so obviously our first option is possibly to observe them if the tumor is discovered incidentally, and then to consider other options, which include surgery, radiosurgery, fractionated radiotherapy. And it's important the residents keep forgetting that you're not treating the scan, you're treating the patient. So there's been a move away over the last 30 years from very aggressive surgical approaches, which caused a lot of morbidity, to more limited and combinatorial approaches to improve the patient's outcome and quality of life. So it's not all about the scan, thank goodness. And patients are glad for that. Now, the morbidity and related to treatment relates to the surgeon, the tumor, and may be patient related. So the surgeon has experience. Fred Barker, Will Curry, and I wrote up a paper many years ago looking at the morbidity associated with experience, and large volume centers actually had the highest short-term morbidity, but good overall outcome and increased likelihood of discharge to home. There's tumor factors, obviously, you know about this for different locations. Petroclival, I was used to tell the residents I asked them, what's the likelihood of at least a transient new neurologic deficit after a posterior petrosal approach for a petroclival meningioma? And they would say, oh, no, like 8 to 10%. No, it's 100%. Because they all get some conductive hearing loss from the petrosectomy. They may get facial numbness, double vision, etc. And some of the morbidity is patient-related if they have a lot of medical comorbidities or they're extremely heavy. we looked at risk factors for serious medical complications. And in 834 patients, there were 6.8% that experienced major medical morbidity, and 4 patients died for a low incidence of 0.5% mortality. But there were other complications that were common. So nothing is for free. And especially when you get into eloquent areas like cavernous sinus region, there's been a lot written about this. Part of the problem with this topic is the definition of what a cavernous sinus meningioma is. Is it just confined to the cavernous sinus or involve other adjacent compartments? But we won't get into that. But look at the pooled mixed effects of cranial neuropathy rates from this paper by Mike Shagru. Any kind of surgery associated with a 60% likelihood of new cranial neuropathy, and radial surgery about 25% from the literature. So in another paper proposing a treatment algorithm for meningiomas based on a retrospective analysis of a number of approaches, just look at this column here of late postoperative cranial neuropathy and look at the numbers. These are percents, 50%, 80%, 16, 12. So the morbidity can be exceedingly high with some of the things that we think are, quote, standard operations. Here's a paper looking at LINAC-based radiosurgery, conclusion that it was safe and effective. There were 15 patients who had new cranial neuropathy in that group. Here's another paper looking at 100 patients. This is a paper from Europe, published in 2010. Good long-term follow-up. Morbidity was limited. So again, a non-invasive technique that provides low complication rates, and we presume some advantage in terms of quality of life, but not measured, not stated. So how is outcome usually measured? It's usually measured by surgeons based on the extent of resection, that being the Simpson grade, gross total, subtotal, etc. Recurrence rates, freedom from progression. Overall survival is kind of a mixed, difficult bag but we often report it, but we rarely report quality of life, and we use a number of different instruments, as I'm going to show you, which is a problem, but we're, I think, working internationally to come up with a solution. Now, if these are the desired results, undesirable results are complications early and late, transient, and permanent. And the way we've measured quality of life in the past is actually kind of pathetic, because we've used the Karnofsky performance scale, which was developed in 1949 by David Karnofsky to assess the toxicity of nitrogen mustard in the treatment of lung cancer patients. So this really is a very general assessment of the patient's functional abilities, but not specific and not detailed enough for some of the patients that we look after. And if you look at a retrospective review, for example, from a single surgeon on the role of microsurgery and stereotactic radiosurgery, looked very briefly at symptoms and proposed that, in fact, in follow-up patients, whether they had surgery or radiosurgery, got better over time, which was normal recovery. But this is really not a quantitative analysis of the patient's quality of life using a KPS, which gives very broad categories for recovery. So in 1993, a group of oncologists decided that the KPS was too limiting, and so they collated 170 questions and came up with this functional assessment for the treatment of cancer in 4 broad domains: physical well-being, social family well-being, emotional and functional well-being. And then in 1995, a group of neuro-oncologists, MD Anderson, decided to add a brain subscale, and these were the additional concerns that they thought related to neurologic function, which were, a little bit better than before, but generally broad. And this was called the FACT-BR. So I think it was back in the 90s, Steve Kalkanis, Alfredo Quinones, and Peter Black reported on a group of meningiomas operated at Brigham and Women's Hospital and looked at the self-reported quality of life in patients, and in specifically related to the neurologic domain. And if you look over here at this column, look at the numbers about, are you having difficulty with work? Is work fulfilling? Yes. Have you been able to work? 64%. Have you accepted your illness? most of them. So, you know, I thought it was a better approach to analyzing the outcome for patients, but it wasn't tumor site specific. So we recognize there's a big difference operating on a convexity meningioma versus a posterior fossa or skull-based meningioma. So we thought that it would be important to look at site-specific questions. And in this publication from about 18 years ago, we looked at 38 papers at the time, and the quality of life measures were only in about half of them. 2 of the 15 used the SF-36, 5 out of 15 used the FACT-BR, and 8 out of 15 used the KPS, and none had site-specific questions. So clearly, parasagittal meningioma would have a different presentation than the sphenoid wing meningioma, that would have a different presentation related to foramen magnum or cerebellopontine angle meningioma. So we added in some questions, took a first run at this, and we called it FACT meningioma. And what we did was looked at both the SF-36 and the 4 main domains that we discussed before in FACT-BR. We used all the questions from FACT-BR and then 5 additional questions from the SF-36. We didn't generate our own question set, as some other groups have done. But then we added site-specific questions for the 11 classic meningioma sites. We were able to develop a web-based instrument for the patients to self-report. It's a radio button question. It takes about 12 minutes to do it. So these are the SF-36 questions that were incorporated into the instrument that we used, following the same profile, not at all to very much, a number of different questions. And then we had the 4 main domains and the additional concerns that were in the FACT-BR. And then we, these are some of the example questions in physical well-being. I'm forced to spend time in bed. I have difficulty walking several blocks. I have difficulty dressing myself. Social well-being. I feel close to my friends. My family's accepted my illness, etc., etc. Emotional well-being, looking at factors that might relate to depression, fear of death. Functional well-being, you can read the questions here. I'm sleeping well, I do the things I usually do for fun, etc. And then the additional concerns that were in the initial FACT-BR. Then we added site-specific questions. So for example, for parasagittal and falcine meningiomas that can occur in the anterior, middle, or posterior third, we put in for the anterior third, my short-term memory is worse. Middle third, my leg is weak, my leg is numb, my arm is weak, my arm is numb. And for the posterior third, I have a blind spot in my vision. And these were taken from the classic clinical symptoms that patients with tumors in these locations would usually present with. Cerebellopontine angle, numbness, pain, hearing problems, ring in the ear, weakness of their face, dizziness, balance worse, coordination affected. And then you can see the other questions that were specific for olfactory groove, optic nerve, sphenoid wing, CP angle, convexity, etc., etc. So we analyzed, or I think we recorded data on 219 patients at UCSF. And I thought it was interesting looking back at one of my patients through the chart, a petroclival meningioma, a small tumor, operated on the patient, did well in terms of extent of resection, no residual visible tumor on imaging. The surgeons, my impression was the patient's doing well. And when the patient filled out their questionnaire, they said they weren't doing that well. Vision was very much altered. They had double vision. Short-term memory was worse. Coordination affected. Arm coordination somewhat. Balance is worse than prior to treatment. And this was an early phase, 3-month post-op assessment. What about a cavernous sinus meningioma, small, no surgery, treated with radiotherapy for imaging progression? Surgeon's impression was scan looked stable, didn't say much about the patient's function, but again, more symptoms than the physician would ever elicit in a short office visit. So eventually this is going to be important because insurers are going to be paying for quality outcome, not the fact that you actually did the operation. So we worked with a web-based company to enroll patients. We had 219 from UCSF. I paid for the initial registration of 14 sites around the world, but only 5 other sites actually registered patients. Queens Square Hospital, Henry Ford, Vancouver General Toronto, University of Toronto, and then Brigham and Women's Hospital. And you can see the distribution of tumor locations, kind of what you'd expect. Parasagittal falx and convexity, the most common. And then one of the problems with any kind of follow-up system is that even though the patients get automated email reminders to complete their forms, they're not very good at it. So we had to hire a full-time research associate to, call the patients up physically on the phone and go through the questionnaire with them. And you can look at the compliance about how variable it is. The registration of the patient is actually pretty simple. And the clinical nurse specialist or the research associate will sign the patient up. If they agree, they have to sign a consent form. The system's all HIPAA compliance, been used by multiple other clinical research groups. You can even use a QR code, scan it, and load up the questionnaire on your iPhone, which is helpful. So we haven't analyzed the data yet. I came to Baptist 2 years ago. I had a number of other things to get done, but about 6 months ago, we started the process of getting the IRB through for using this quality of life assessment instrument, and we received approval a month ago. On Friday, we had our first team meeting to go over the process about what the system looks like and how to register patients with our nurse practitioners. So it's not a simple process, as clinical researchers know. So what's the recent literature show? Well, when I looked up PubMed last week and put quality of life and then the Boolean operator and in capitals with meningioma, I came up with 345 articles, but I picked of 6, and of the 6, I only focused on 4 of them, and I'll go through them with you now. But this is the University of Toronto group, Galleray's group, Mike Cusimano, and the instruments used here were the SF36 FACBR and EQ5D, but they had a process for intertest and validation and reliability. And they had an interesting approach in terms of item generation, where they interviewed patients and came up with a series of questions, came up with 187 items and went through this process. And then they whittled it down to 162 questions. They looked at test, retest reliability, concurrent validity with subscales from the SF36 FACBR and the other instrument that I measured, and then extreme group validity they also assessed. Now, there were only 30 patients in the group. You can see the distribution here. Some of them were one was pre-radiotherapy, and 6 were post-radiotherapy. And these were the relationships between the patient and the caregiver. And on the validation testing about the reliability testing, test, retest reliability, you can see there were 4 domains where there was very good correlation coefficient above 0.75, which is taken as significant. And then concurrent validity, comparing them to other assessment scales, you can see the correlation coefficients here. So a wide degree of variability across some of the more standard 4 main domains. So a very good effort, still not perfect, but at least it's a validated instrument. And for example, the one that we developed was never validated. And so we're going to be working on that. This is the Dutch group that looked at health-related quality of life, neurocognitive functioning in skull-based patients. They used the 2 instruments here, the SF36 and EORTC questionnaire, similar kind of process for including, excluding patients from the study. And these are the results in some of the main quality of life domains. There's not much of a difference between controls and skull-based versus controls and convexity. If you look across here and look at the error bars, not a big difference. If you look at skull-based and convexity, same thing, not a big difference. There is a difference between anterior and middle skull-based versus posterior skull-based, and the posterior skull-based patients tend to have greater symptomatology and are associated with a worse quality of life. And it was interesting that primary treatment with radiotherapy was also associated with a worse health-related quality of life outcome. But the limitation, as the author stated, was that the questionnaire used to assess the health-related quality of life were not developed for or validated in meningioma patients. So that's a problem. The Toronto group developed their questionnaire, by interviewing patients, and then they validate it. So it's a more reliable and robust questionnaire to be using. We know the trend is going to be discussed at the upcoming AANS meeting about endoscopic versus transcranial approaches. And, you know, there's some morbidity, nasal morbidity, just related to an endonasal approach, increases with the raising of a nasal septal mucosal flap. And I love the ENT people. They have a questionnaire about nasal quality of life called SNOT, how appropriate. But this is not surprising to surgeons that, you know, patients' overall quality of life and sinonasal quality of life goes down in the first 3 weeks after surgery, and then eventually recovers. And if you look specifically at olfaction and taste, it's said that simply doing a nasal septal mucosal flap results in about a 30% incidence of anosmia. And the most common cause of anosmia is upper respiratory tract viral infection, not COVID. But you can see that olfaction declines quickly after the operation and recovers over time, but not back to normal. And same with taste. You know, these are factors that are major considerations in quality of life. I mean, these patients have to irrigate their nose 2 or 3 times a day for the first 6 to 8 weeks, and then usually once a day, ongoing for many months in order to keep their airways clear. Now, sometimes we make decisions about patients for surgery that are not based on tumor factors, but based on patient factors. And that is, we think that if there's overwhelming anxiety or if there's a significant distress burden related to the diagnosis of meningioma, sometimes the patients will want their meningioma removed so that the problem's behind them. And this study was interesting that they found that distress and quality of life did not change over time in patients who were either operated or managed conservatively. And so, you know, I think once the diagnosis is made, whether you treat the patient or not, you can expect that these patients are going to have some ongoing issues, emotional and distress issues, so-called distress thermometer scale. This is DT down here. So a significant number of patients still have problems. There's no difference whether you observe the patient or whether you've treated them surgically. This paper was from the Dutch consortium looking not at the patient, but at the caregiver. So the spouse, the daughter, the son, etc. 34% of meningioma caregivers report clinically relevant caregiver burden. And the caregiver burden was associated with lower health-related quality of life, more anxiety and depression. And caregiver support could not only benefit the caregivers, but also the patients. So we would never think about this in a meningioma surgical clinic post-op, but it's a significant factor. And, you know, I saw a patient last week that I operated on in September of 1993. He was 23 years old. I followed him for a year before I operated on him. So I started following in September of 1992. Now he's 54. He's got an 18 and a 20-year-old son and daughter. And he's got multiple meningiomas. He's had radiosurgery 4 times. He's had surgery once. He's got 2 spinal meningiomas. And I can tell you that even though he looks like he's successful, his anxiety and his wife's anxiety related to this disease, having been followed for 30 years, is significant. But to their credit, they've made it through. And, you know, it's something we really don't think about. This was how the investigators looked at the caregivers' overall responses to looking after patients. You can see here a number of measures: general health, mental health, vitality, etc. These are the caregivers. They're all negative. And they have increased depression, anxiety compared to normal. So it's not an insignificant burden. And this is a benign tumor condition that frequently is lifelong and has a 50% recurrence rate at 20 years post-op or post-treatment. Not insignificant. So one of the problems is that these, you know, we've all done our effort to try and look at quality of life, looking beyond the post-op MR scan or the white dot on the scan. But if you look at the different groups, UCSF, U of T, Netherlands, Australia, 4 out of the 5 use the SF36 plus something else, and 4 out of the 5 used altogether different combinations. There's no consistency here for us to be able to compare apples to apples with different kinds of treatment. And Michael Jenkinson, who's a neurosurgeon in Liverpool, England, is currently involved in 3 studies, a radiation study, seizure prophylaxis study, and then the likelihood of tumor recurrence and predicting recurrence tumor, but the outcome measures they're using are different for all 3 studies. So that was the impetus for his group and Christopher Millward to put together an international group. Gelleray's on this, I'm on it, a number of other people from around the world actually, to come up with a core outcome set in neuro-oncology, and specifically for meningioma called the COSMIC study. So core outcome sets for meningiomas in clinical studies. And, you know, it's basically to come up with a set of minimum outcomes that should be reported in meningioma clinical effectiveness trials, so-called COSMIC intervention, and can be used for incidental and untreated meningiomas. So the overall plan for this project involves a number of stages. We're in stage 2 now. I think the paper it's been accepted with revisions. So this will be published as part of a recommendation for a protocol. You can actually go on, they have their own website, core outcome sets for meningiomas in clinical studies. And the purpose is to, you know, have a minimum set that you would be able to use to report your clinical, your treatment effects. But you can add on anything you want in addition to this core outcome set. So you're not University of Toronto, UCSF, Baptist, Netherlands, they can add on whatever they want. But if they have the core set of outcomes for quality of life, then we'll be able to look at each other and realize that, or see how we're doing across the board. And this is the clinical group of international collaborators and the study management group. Michael Jenkinson shared some of these slides for me to be able to present today, but you can go on to the cosmicproject.org website and look all this up. So one conclusion slide, and that is that I think meningiomas are, their symptomatology and presentation is unique by location, and they lend themselves to more specific quality of life assessments, certainly more than the Karnofsky. But I think we should, you know, look at site-specific questions that might provide us more information, more detail. We tried to do this with our quality of life assessment, but we haven't validated yet, but we're going to try and do that. And I think the take-home message is that clinical studies, whether it's observation, surgery, radiosurgery, radiation therapy, or some form of chemotherapy, need to incorporate a core set of quality of life measures, and that this same scale should be used by all those investigating meningioma therapies, and that's the COSMIC project, coordinated out of Liverpool, England. So that's all I have to say. Thanks for your attention. Here we are.
Thanks, Dr. McDermott. That was a great talk, and it does highlight, you know, things that we don't catch in surgical clinic, because, you know, we're so focused on imaging and surgical resection that we forget the person behind it. And it is very important for us and our trainees to realize that and take that into consideration.
Yeah, I loved when my Manish is on the call now. He'll remember that we had to institute a mandatory clinic attendance by the chief residents. You know, just love to operate, right? That's their nature. And 3 of them, you all know these people. I'm not going to mention the name, but every single one of them said to me, you know, I'm surprised you're not operating on more of these patients. And I'm like, well, I can't. I'm supposed to make them better with an operation. And if I do an operation, I'm exposing them to risk. And then even beyond that, look at all the other things we're exposing the caregivers to. You know what I mean?
Absolutely.
And we never think about that. So anyway, it's a tough problem. But I think meningiomas are a lifelong condition, and you have to follow the patients for your career.
Yeah, And that's what makes it more, like the burden on caregiver is much longer compared to high-grade malignancies, where it's tragic overall, but all the effort are kind of aggregated up front.
Yeah. Yeah, I know. I mean, you know, we think we have problems every day, but you know, all you have to do is go to the cancer clinic or something and just realize, oh my God, you know, poor souls. It's brutal. And somebody knows why these things happen, but it's not us. And the patients and families, you know, they do their best. God bless them, but it's tough. No question.
Mike, hey, it's Joe Bovi. It's good seeing you again.
Yeah. Hi, Joe.
Yeah, we keep threatening to actually invite you to the state of Wisconsin instead of doing this virtually. I promise that'll happen, and you and Wade can go race some cars someplace.
Yeah. Okay.
Hey, I was really impressed by your talk. Thank you so much for agreeing to do this. I was really struck, actually, and we can probably just move into the panel discussion at this point if our other two discussants could jump on as well. I was really struck, actually, by the international efforts, actually, that are being undertaken in the realm of meningioma, and it's just really amazing and staggering work. Specifically with regard to your talk on quality, do you think, you know, kind of taking into account Dr. Zeta's work with molecular, in addition to some of these international efforts with regard to quality of life, there'll actually be quality of life metrics that will better define best course for care or best course for treatment for folks? Is that one of the aims of that cosmic project as well?
Yeah, I think so. I mean, I'm the oldest guy on the call for sure today, and I've been the one that has been through the whole cycle from the late 80s, early 90s of the super aggressive skull base surgery. And, you know, all my colleagues, Bill Caldwell, there's a couple of outliers still, but everybody's basically come around to realize that, you know, if the operation's going well and everything's going smoothly, get the whole tumor out, great. But if you run into a situation where you, as the surgeon, make a decision that the risk for getting that last 10 or 20% is too high and you stop, it's not you feel like you failed, but you're not a failure. That you made the right decision, because the last 10% is 90% of the difficulty, so to speak, or something like that. And I think, you know, I used to feel really disappointed if I couldn't get the whole tumor out. I was like, you know, what am I doing wrong? And I should have done this. But I think frequently it's the tumor that was the local anatomy that made it unresectable, not lack of surgical technique. And the important thing is not to press on when you're confronted with an unsolvable situation, because you'll only hurt the patient.
Yeah, I think that's great advice. Good for the trainees on the call to hear the same. Dr. Zeta, thank you so much for rejoining the panel. As I'd mentioned earlier, after your talk, was just blown away by your efforts in Toronto and all the great things that you are doing up there. I'm curious, for those of us who don't have all those tools at our disposal at this point, and you know, perhaps you and Dr. Helgager could comment on this as well. You know, what's a good middle ground for you know, doing some additional molecular characterization of these tumors with current tools that we have at hand? Jeff, you'd mentioned, you know, 10-pus testing on some of these malignancies, but just based upon Dr. Zeta's talk as well, that's only going to give you part of the story. Where do you think the middle ground is on analysis of these meningiomas in order to better define perhaps even those that we should observe postoperatively, those that we should consider adjuvant radiation therapy on, until this molecular grouping really takes over for the WHO grading system?
Yeah, that's a really good question. Again, thank you for inviting me to be part of the discussion. I would say confidently, I think the nomogram is helpful. It's taken us approximately from the time we finished the study, published it, 2019 to now, 2 years to have all team members agree upon its value, and so we do regularly use it at Tumor Board, to the point where I have to say I'm very positively encouraged that it's actually not me suggesting that we use the methylation for meningiomas. Our radiation oncologists, sometimes actually our pathologists mainly, then request that we do methylation, and we do the nomogram. The nomogram has now been made into a website, so if you had facilities to get the IDAT files on the methylation, you can really upload all the information and the nomogram is produced. What has happened, because the methylation, though, I think, you know, if you look at our study, we started it in Toronto in 2017, roughly about 5 years ago. It is not a technology that can be incorporated into every institution. So as a result, I think there's key referral centers. So in Canada, we tend to serve that role, and then for some centers in North America. I know NIH, where Ken Aldape moved to, serves as a referral center as well. NYU, where Dr. Snuderl is, etc. And the reason I think this is the most practical is each patient that has perhaps a meningioma that's not the most straightforward. So if on histopathology it's very clear that it's benign, the surgeon is very happy with the extent of resection, you would consider that straightforward. But if there's anything concerning a higher MIB, features to the pathologist, features to the surgeon on imaging that's concerning, and all grade 2s and 3s, what we suggest is that 5 unstained cuts of the paraffin be sent to us. We extract the DNA, and then we produce the IDAT file and the nomogram for the center. And we do this in a turnaround time of 2 weeks. Given our healthcare system being social, I can't actually really charge anybody for it. I can send an invoice, but that's about it. There's no point, so I don't go chasing anybody. But cost effectiveness of it, actually, for other tumors, if you think of gliomas, it replaces 1p19q, IgH status, MGMT. But going back to the meningiomas, I do think currently that would be the most practical, genuine impact on clinical decision making for grade 2s, grade 3s, and grade 1s that have concerning features, whether histopathology, clinically, or neuroimaging. And then to one of the centers to have the methylation done, and then we can do the predicting modeling for every patient. I agree, getting to a point where you can have the stains validated is another big undertaking for the studies that I showed you for MG1 to MG4, but that I think will happen in the next couple of years. But right now, I think that would be the practical, genuinely impactful middle ground. I mean, we've now got approximately 300 meningiomas that fall in that category that we've monitored prospectively, and the results seem to hold valid.
So I have a question. So when you showed the breakdown of methylation by WHO class 1, even within class 1, there are certain tumors that are by methylation pattern seems to be more prone to recurrence compared to others. Does that correlate with the concerning features that you would think on a histology to know that we should send that and they will most likely fall into that higher recurrence rate group?
Yeah, I see what you mean. So is the poor outcome or unfavorable outcome in grade 1 a tumor that would have a higher Ki67, for example?
Right.
Yeah, that's a very good question. So we don't routinely do Ki67 on our meningiomas, so I can't answer that with certainty. However, the ones that have a high Ki67 on methylation show a more aggressive behavior. I think I understood your question, right?
Yeah, yeah. Mm-hmm.
Yeah, one thing that the pathologist will love is if we have a templated gene sequence or profiling thing that's like a box, put the tissue in. They won't have to sit there and count stain cells with Ki67 for the labeling index, because that's tedious.
I can tell you
and
that it took me a long time.
yeah. And just to send the ones that you are suspicious of, first we have to know what we're suspicious of to send them for methylation. So if Ki67
Yeah, I mean,
is
that's right,
that,
for the grade ones. The truth is, if you, I mean, we do it for all our meningiomas. I'm just saying, Dr. Bovi asked what's the middle ground. That's what I was saying. But for our meningiomas, we do methylation on all of them.
Yeah.
Because it's a good data set also for us to accumulate.
I mean, in my experience, the biggest thing, of course, is just simply getting, basically insurance to pay for these things, and that's been the biggest issue. It's they don't even want to pay for NGS sequencing on it, and they're going, well, that's not indicated, that's not the standard right now, and well, so that's really a problem. But like things.
And I think that's true, which is why I think NIH is a referral center, and for us, we're a referral center because I can't
it's just
charge.
Yeah.
And NIH doesn't charge, right?
Yeah. I mean, the thing is really implicating coming up with something where you're doing this on, every single tumor, which is really what you want to be doing, because there's going to be ones that are, they look like grade ones, but they have molecular, findings in them that are going to be indicative of more aggressive behavior. And that does happen, so it's just, we used to where I trained, we sent for example, array on every single one. And a lot of times that would really inform, like let's say you're at grade one, but you got, this complex karyotype back. It's like, well, that really informs this is probably going to be more aggressive, and that's not obviously as good as the methylation data, but it's nice to have that backup, even if it's not used for grading. So I'd really like to have something like that, but it's really just a matter of being able to actually get something like that going that can be basically reimbursed. So that's the big thing. Though I definitely understand, the idea of sending things out if you have, just in a minority of cases, if you have questions, which I've done, if there's specific reasons to do it, I can send it for methylation, but I just can't do it, all the time. That's the thing. So.
Yeah, I understand.
What I think is really cool, obviously, if you have tissue, then you can, run it through any kind of sequencing or staining and the like. But in patients who we observe, where we can't, the patients are going to ask, what's our likelihood? What's my likelihood of having the tumor grow? And we use kind of really crude radiographic features to give them that prediction. But if you use artificial intelligence and look at features available on MR, you can really, it's really powerful. And so I don't think we should forget that. I'm hoping that the physicists and neuroradiologists will come up with some kind of standardized AI analysis of the MR imaging rather than just the radiologist report that will give us a prediction index for the risk of tumor growth in the future.
Well, perhaps even relevant to Dr. Palmer's talk this morning, we expand our integrated diagnosis across both the pathology and radiographic report. That may be more so the whole picture, Mike. It's a great point.
Joe, I just want to let you know that I was at the racetrack on Thursday and I did 38 laps in a KTM Expo.
and you're still alive.
Yes. Every 2 months. Anytime you come down to Florida, if you want to go, let me know.
All right. That sounds great.
Anybody, Galleray.
I think I'll melt.
Yeah. Well,
I don't know what sun is like anymore.
Yeah. Funny.
This was an amazing morning, you guys. I can't thank you enough. We're at time, and to be respectful to you guys as panelists and our attendees, we'll wrap things up. Personally, just very touched by all of these talks today. They were just absolutely wonderful. Exceeded my expectations really in every way. This was just a wonderful, wonderful morning, and I appreciate you guys taking time out. I know here in Wisconsin, it's literally the most beautiful day outside right now that we've had in like 7 months. So for those of you who are here from Wisconsin, thank you so much. Our other national attendees, hopefully weather is as kind for you wherever you're at.
Yeah, and I would echo Dr. Bovi's thought. It was great, and it was really a pleasure having all of you do this on a Saturday morning. So which we really appreciate. And I would really like to also thank Chad and Brittany for all the technical assistance that went into a CME symposium, and Sarah for all the help. But it was great connecting with a lot of you and knowing a lot of making new connections.
Thank you.
Thank
guys.
you.
Thanks.
Bye-bye.
Bye-bye.
Thank you. Bye-bye.